pressure. We will all learn. 10 minutes you can buck up. So, how many of us have not used AI in your practice at all? Can you just raise your hands? Okay. So many of you had not used. So it is not so. We all have been using AI in your clinical practice. Say for example, we all would have seen our ECG machine which comes out with a printout or interpretation, isn't it? That is also a form of AI. Or if you see your Google Maps, nobody has not used Google Maps, isn't it? So that is also a form of AI. So this artificial intelligence is way there, like it has been there for a long period of time, but we have been using it only of late in a different format. That is what we are going to see. Then when the primitive form of AI came, we then landed up with something called as machine learning. So machine learning is, say if you are doing like Facebook or YouTube, something like that, you start seeing something about some actress, Samantha or so, or Nayantara. So it will always keep showing the same repetitive forms. That is machine learning. Machine was learning how you are using your prompts, and it was coding it for you and giving you the suggestions. So that is machine learning. Then came what we call it as deep learning. In deep learning, say for example, you have a Microsoft Word. If you tell the word, it will try to recognize the text and start putting it as a word format. So that is called as deep learning. You give it in one format, the machine is giving it in another format, but it cannot interpret what you say. Okay, so that is deep learning. How this deep learning happened? So it is all based on this, something called as neural network. In neural network, exactly like how our brain works, it is trying to interpret what you say and give it in a different form. So this is neural network. Now what interests us all to come to this session is something called as generative AI, where this neural network, so instead of one brain, if 1,000 brains are there, or if 10,000 brains are there, what will happen? It will have enormous knowledge, where you give it in one format, you give it as a chat format, it will give it out as a printout format, or get it converted. It starts thinking, interpreting, and give out in another format. So you can generate it as an image, you can generate it as a PDF file, all these things can happen. So this is what interests us, what we call it as a generative AI. So these generative AIs are based on this very good model of something called as large language model. In this large language model, it is something like, say, a kid which is learning the language. So that is deep network. So if somebody becomes a very learned person, it is all LLM, large language models. They have absorbed all this knowledge and try to give its gist, or try to give its gyan. It gives its knowledge in another format. So that is what these generative AIs do. Now, this generative AIs, we need to understand they are not a search engine. It is not Google. It is not a search engine. We should understand this difference. So something which we need to fundamentally know. Many of us wouldn't have used. So say suppose if I want to use Trac2025, you can use it in three formats. So either as a you can go to the website and do it, or there are desktop formats which are available, or in a browser also available, or there is an app which is there. So every AI has got this sort of formats, three formats that we can use. Now what is important is when these large language models are giving it as an output, we have to give something called as prompt. So let us go to a restaurant. Now you order a rava dosa. கல்லுல நல்லா போட்டு நல்லா ஒரு நிட்டு கொஞ்சமா வெங்காயம் போட்டு பொடி போட்டு அதுல கொஞ்சோண்டு நெய் ஊத்தி லைட்டா ஒரு முந்திரி போட்டு நல்லா முருகலா எனக்கு சூடா வரணும் அப்படின்னு எப்படி சொல்றீங்களோ அது மாதிரி you have to give something called as prompt. Unless you give a prompt, then you are going to the restaurant, that is called as an interface. The kitchen is the large language model and the output is the dosa. If you want the dosa to come out as you need to know how good you are doing prompt. So prompt is called prompt engineering. They gave various names to all these things, but fundamentally we need to understand the very good the format is, the very good the output will be. If you all want to learn a single skill today, it should be what is called as this prompt engineering is the most important. The format for a good prompt will be who am I? So what am I doing? And we should ask what role the generative AI or what role the language model should take. So I am a doctor, you are going to give an output for a doctor. So you should define it very clearly. what is the task? What is the task that we are asking the machine to do? How do you want the output? Say like you want it as a PDF, you want it as an image, you want it as a video, or you want it to explain to a 6-year-old kid. You have to explain this to the machine in the form of a prompt. Say for example, three things are very important. You should know what is the role, what is the task, what is the format. So your prompt should match all these three things. So when we say, I am a physician, I want the summary for the physician. You have defined the role. Your role, what machine the machine has to take. I want you to read and interpret the article. We may be attaching it as a PDF. It has to read and interpret it. That is what the task that you are asking the machine to do. And what do you want to do? Give it in the form of a format. So format will be like, it will be a plain text summary, or you may ask to give it as an image or a video, or so and so. So that is a format. So your prompt should involve these three fundamental elements. What is its role? What task you need to give? And what format you want the output will be. There are so much of apps that we have, but what we need to know is you have to individualize the apps. So that is very, very important. So what I mean to say is, these large language models, they are designed to give the output only for the desired task. You can't go and sit in an Indian restaurant and ask for a Chinese food. So this large language model should have the kitchen to equip ourselves. So to give the desired output. That can be possible only when you go to the particular restaurant. So you should land up with a particular app. See, if you see this ECG, just see this ECG and find how you are findings, your own findings. Now I am trying to ask ChatGPT what will happen for this ECG. The patient came with a history of 2 days of chest pain. Now I will give what ChatGPT gives. So I have given the ECG. The ECG is telling some findings like. That's okay. So I'm trying to attach this ECG and ask it what is the finding of it. What happens to this patient. So I'm sorry, like technical glitch is not showing clearly, but are there, and I'm telling like, is there an ST elevation which is there in the ECG? Are you able to see? So the ChatGPT then recognizes that yes, there is an ST elevation. See, what do we want when we try to do this sort of prompting and ask the this generative AIs? It should be able to tell us very clearly what is happening there. The ChatGPT actually had missed what the changes over there. If you see in the ECG, there are some subtle findings which are not picked by the ChatGPT. So there are some changes in the V1, like there is an ST elevation which the ChatGPT is missing. So what do we need to understand over here is the ChatGPT is not tuned to find out all these things, or it doesn't have the ingredient to pick up all these changes. So you should not ask ChatGPT. Rather, you should ask an AI app which has been fed all these things. So if you want to interpret your retinal image, the app should have fed all these changes, and that should be able to reflect what is happening over there. Now, ChatGPT is not good in picking all these things. So when you give a, say, based on this German model, when they are able to give to this app, so this is called as a, let's just show this video. So it is telling very, very clearly that there is an acute occlusive myocardial infarction. There is an acute and high confidence. So this app is not missing it. So we should learn that the fundamental point that we need to know is you should know where you should ask your question. If you ask your ChatGPT, it will miss because it is not tuned to say what you want to do. So say, for example, if you want to ask something about YouTube, so what is the content of this YouTube? If you put the link in ChatGPT, it will not give. Rather, what you should do, you should give it, go to Gemini and give what is the content of this YouTube. Say, there is a 4-hour lecture. What book has been discussed in this YouTube? So if you take the link and post it in Google Gemini, it will exactly give in 1 minute. You don't need to see the 2-hour lecture at all. Or if you want to sum it up, the Google Gemini will give. So fundamentally, we have to know like these generative AIs are tuned for a specific task. So you should know what you are asking with your prompt. Second, whether that has been already fed to the large language model. Then only it will be able to give the output. So these are the two important carry-home messages which you need to take from this introductory, because based on this, the other panelists will be discussing what are all the apps you can do for your respective settings. Now I will ask Dr. Mahesh Babu sir to take over the next set of apps how you can use. We will discuss about all those things later. If you have any questions, you can ask us.
There will be some overlap between the previous presentation and this presentation, but here we will be reinforcement for you. So AI is more evolving field. So what is there? Is a more evolving field. What is there today may not be there tomorrow, and maybe in the next year, someone is presenting about AI. What I talk today maybe become totally void. So let me go into the topic proper. So the definition of AI is started. So there are. So I am going to discuss about two tools today: how to use it for patient education and how to use it for self-education or doctor self-education. So I think most of you will be having this apps like ChatGPT, Gemini, and Notebook, and there is something new about it. We'll talk about Notebook also. So before going into any apps, we should know how to ask a question to this AI. So AI is a knowledge box. It has everything in it, but does not know what you need. So only if you ask a proper question, will come out here proper right. So prompt is a carefully crafted input to guide the generative AI model towards a desired output. And this serves as a starting point for all AI response, and significantly enhances the quality and relevance of the result. So when a prompt is given properly, you will get the output properly. So the quality of a prompt directly impacts the usefulness of the AI's response. And prompt construction is critical skills told by Dr. Gautam. Today you will learn how to give a prompt to the AI. So most of us are using these apps, but we do not know how to prompt these AI apps. So these are the common, as we are medical students, we used to have some mnemonics. So this is a common mnemonic that you can apply in your routine life. So you have to start with a role. So as specified by Dr. Gautam, I am a doctor, or I am a physician, or I am an endocrinologist. Like that, you have to give a role first. Then what is the action? So I need to design a diabetic diet plan, or I need to give a lecture on pathophysiology of type 2 diabetes, or I need to give a lecture on GLP-1 receptor agonist. So what are the steps? You give introduction, pathophysiology, mechanism of action of drugs, clinical trials, and like that. So and you have also, you can also add some content to that, and you can use some examples of what you need, and you can also ask them to come out in the format like PDF format or PPT format or video format. So this is the first thing which you are going to learn about how to use this apps for patient education. So how to give a prompt by the patient. So I am a diabetic for past 15 years. I am a office worker, sit for a long time in a chair. So that is the role. And second point is I need a diet plan to control my blood sugar fluctuations. That is the action. And give a diet plan for breakfast, lunch, and dinner. So that is the steps and content. So the content is, example is include some veg as well as non-veg food items like fish, prawns, and liver. So those are the content and examples. Give it in a word format. So we are going to give it to the system. That is here we have used Trac2025. So we are going to paste the same thing here and see the results. So it will immediately give the detailed diet plan, and it will also calculate the amount of protein, carbs, and fat in each and every diet. And even if you want for an entire week, starting from Monday to Saturday, all the 3 meals, it will give it in a tabular form, and it will calculate the calorie content of the food. So இப்போ நம்ம பேஷண்ட்ஸ் சார் டயட் சார்ட் கொடுத்துருக்கீங்க, நான் சாப்பிட்ற ஃபுட்டில் வந்து எப்படி எவ்வளோ கேலரி இருக்குன்னு நான் எப்படி கண்டுபிடிக்கிறது அப்படின்னு கேட்டாங்கன்னா, நெக்ஸ்ட் யூ கேன் how to calculate the calorie by using AI. ஒன்றுமே கிடையாது, just take the photo of the food, upload it, it will give the calories. So இன்னைக்கு breakfast நீங்கள் என்ன சாப்பிட போகிறீங்கன்றத catch a photo and we will upload it, find calories, it will give the calories. Very simple tool, each and every one of your patient can use. So இன்னைக்கு வந்து நீ 1500 calories சாப்பிடணும் அப்படின்னு சொல்லியிருந்தோம்னா, patient can take each and every food photography and they can upload it in the Trac2025 and they can find the answer. So see, you can see this traditional Indian breakfast. This is going to have a calorie of around 770 kilocalories. Okay. So next we are going to take a photograph of a diabetic diet, like ragi dosa, and we are going to upload it and find out how much kilocalories it is going to have. So it is very simple. So patients can take a photograph of their family members, what they are taking, and what is the diabetic diet they are taking. They can compare the calorie count, and then they can decide what food they have to take. So it will have a larger impact on the patient's mind whether they are taking right food or not. Whatever you tell to the patient, finally they do not know what calories is there in their food. So this will help in finding the calories which they are consuming. So you can see that the calorie count is around somewhere between 290 to 300 with the ragi dosas. So next, how to use this AI apps for self-education, like doctors, like for example, if you are in a teaching profession, how to use it for your teaching line. So I am an endocrinologist. I want to explain the pathophysiology of diabetes and role of SGLT2 inhibitors and GLP-1 receptor agonist in type 2 diabetes for medical postgraduate students. So this is the role. First one is the role, next one is the action, and include the themes like ominous apteds and types of SGLT2 receptors, what is incretin effect, what are the available drugs, what are the adverse events, and also include some pictures and charts, include the adverse events like UTI and euglycemic ketoacidosis, give it in a 500 words format. So these are the prompt that you have to give. Only if you give a proper prompt, the results will be good. If you are going to just like that, you type kindly explain the pathophysiology of type 2 diabetes, it will give like a Wikipedia-like thing that everyone has. You can do it in Google. It will give a very big paragraph, which is not useful for your preparation. So now let us see what this is going to give. So we are going to give the same input or same prompt to the ChatGPT. It will give a 500-word document. So similarly, you can download it as a PPT or a video or a PDF file and review it for a future references also. You can store it in your ChatGPT storage also. So whenever you need, you can take back and read it. So most important thing is that you can also prepare a PPT with this. So next we are going to the important tool, that is the Notebook LM, which is a new tool from Google, and it will be more useful for medical students. So unlike other GPTs, here you can upload the documents, like you can upload a PDF file or you can upload a video file, and you can ask it to concise it into a small format. Like if you are having 4 or 5 articles regarding Monjaro, you can upload all the things and you can get a concised article for 500 words or 800 words or in a PPT format or in a PDF format, and use it for future learning. So here we are uploading a Monjaro's cardiovascular protection in diabetes and heart disease and asking it to concise into a small article. So it will immediately give, within fraction of second you can get a small article. And the more important point about this Notebook LLM is, once you download it, you can store it as an audio file. Maybe in future, whenever you go for a walk or a gym, you can hear it over your AirPods. Like an audio conversation, it will be there. So it will be again and again reinforcing into your brain, so that you will have a good knowledge about that particular topic. So in these ways, you can use this Notebook LLM for your clinical purpose. So I think it's done. The take-home message is, AI is an evolving science, keeps on changing. What I talk today may not be fair tomorrow. Everything may change tomorrow even. And prompt is more important and critical. So unlike, this third point is, practice makes perfect. So repeated usage of these AI apps, you can get well versed with the apps. Not only you get well versed, the AI app which you are using is also going to get well versed. So it will accommodate to your own style of asking questions. Unlike our wives who do not understand us properly, this AI app will understand you very well. Thank you.
Thank you, sir. Now, may I request Dr. Manigandan, sir. So, what we have seen is how we can use these apps for patient education and self-education. And another point that we need to know is, especially this LM model, it has something called as mind map. If you attach a PDF file, say it could be 100 MB, 10 MB, whatever be the number of pages, so it gives something called as mind map. Mind map is mind-blowing. Like, it gives how we can understand a concept, like from introduction to abstract to end. Like, it gives you have to use it and see it. Like, mind map is a phenomenal technology. So you can upload a document and go about and seeing the mind map. That is also a beautiful thing about mind map. Now we will listen to how it can be used for clinical practice, how AI apps can be used for clinical practice. Over to Manigandan.
Yeah, good morning to everyone. Thank you, Gauri Shankar sir and Ramesh Babu sir, previous speakers, because they have made it, my topic a little bit easier. They have made it very clear. Like, they have been telling about the importance of prompts and importance in education. Now I'm going to come to this AI in clinical practice. How we can use AI in our clinical practice. So outline of talk is, I'm going to speak about 2 tools. Already they have discussed about ChatGPT. I'm going to see about Perplexity AI and Open Evidence AI, and a device which is a diabetic retinopathy screening device using AI. So coming to the Perplexity AI, just an introduction. It's a large language model based search engine. What is the difference between the ChatGPT is, as you saw, whenever ChatGPT was analyzing, it didn't give you about the source. Whereas the Perplexity AI gives some details about the source and references and offers up-to-date responses. And it is very useful, especially in the point of care of decision making. So I'll simply tell you an example. This happened last week actually. This is a 46-year-old female, known diabetic, presented with an acute onset of this rash for just 3 days. It was non-itchy and non-pruritic. And this was a complaint she was having in both the lower limbs. So actually what happened is, I called my dermatology friend, but he was not available. So what it is, I uploaded here. You can see here. So I just uploaded the image and asked the Perplexity AI about what are the possible diagnosis. No, just I am giving an example. See, what is this? See, I have given identify the skin condition for a female patient who presented with acute onset since 3 days. And the most important thing is, you see that it analyzes these sources that is given here. Almost it's analyzing 20 sources which are relevant to this picture, because that is not seen in ChatGPT. And you see that it summarizes that these are all the lesions which are present: acute bilateral and mildly itchy lesion, and what are the possible differential diagnosis that's made very clearly. You can see that the most differential diagnosis, acute leukocytoclastic vasculitis or HSP, but even though HSP it is not common and as told about thrombocytopenic purpura, and what are the recommendations, diagnosis, how you put forward. For example, you do a CBC and all these things. So in summary, it has given us the most important diagnosis is leukocytoclastic vasculitis and HSP. And most importantly, it has given that even if it is HSP, you should have the triad of renal involvement and arteries should be there, which is not seen in the patient. Now, I have done certain investigations and I uploaded that. So normal CBC, actually I admitted the patient had a normal CBC, normal RFT, LFT, and her ANA was negative, C-ANCA and P-ANCA, everything was negative, and there was no thrombocytopenia. And it analyzes again. We can see that assessing the next steps in the patient management, and it has come to a conclusion clearly that, see, it has given the findings like all ANA, CNA is negative, and next step is, with this result, the likelihood of systemic vasculitis is ruled out, and most important cause can be cutaneous small vessel vasculitis. And what are the recommended steps next? Like symptomatic management is enough, and when to escalate further, whenever the patient lesions become ulcerative, or when the patient develops new lesion, then skin biopsy can be can be done. And it has put it as a very detailed summary table. So this is what happened actually to the patient. I admitted and all the investigations were negative, gave symptomatic treatment, and the patient lesion almost resolved. And now, little bit much more, because I'm lazier, I put that, can you make the course in the hospital for this patient, the discharge summary. It has made it very easily. I think it has made it well in hospital course, and what is this thing? Almost everything. What are the investigation and management, and what advice, progress, how the lesion progress, and discharge plan, what has to be given, everything is given very clearly. So, I think everybody can get astonished with this. See, actually, if we have, because this is based on, if you use this same thing in ChatGPT, it may not be this much effective, because this had been not feeded. As they said, in large language model, you have to repeatedly feed it, because this Perplexity has been made with repeated sources regarding with all this thing, and it analyzes based on the journals, and then it gives the report. So now, next is the open evidence. The open evidence is just advanced to the Perplexity. What it does is, it's a platform that critically appraises clinical evidence using AI. It presents the data in a very structured, clinical-friendly format and transparency with evidence source tagging. I think this is the open evidence AI. You can see that, you can see the reference with this. It has the leading medical information platform on Mayo Clinic platform, NEJM and JAMA. So what are the advantages? You get references from these journals. So the authenticity of the information will be very good in this when you use this platform. And most importantly, open evidence has a number of advantages. Like you can ask a very tough question, like what strategies you use to optimize heart failure management with reduced ejection fraction, or you can even ask the AI to make MCQ questions based on the topic, or you can ask double check or you can ask about any drug interactions, you can ask about treatment options, and you can ask about the recent guidelines. It gives in a very clear way, and you can ask it to do a research topic, and you can ask it to make for a mock exam. These are all the options which are available, and you can ask about the drug side effects, and you can even ask it to construct a workup plan. For example, if you have a hypocalcemia or hypercalciuria, what next to be done, and you can do a number of things, ask about what are the treatment alternatives and everything. Now, actually, I'll give an example for this open evidence, what I did. For example, one of the commonest doubt which we have, what about the antiplatelet therapy which we use, whether to ask this question, what are the evidence and current guidelines about starting a prophylactic antiplatelet therapy in a diabetic patient for primary prevention? So if you see that, it analyzes all the articles. I think that sign is seen there. So and now it has given a practice guidelines, like what the ADS advises. It can be considered as a primary prevention strategy only for those who are at increased cardiovascular risk after a comprehensive discussion with the benefits. It also says that the net benefit is most likely in adults aged more than 50 years with diabetes, and at least one additional major risk factor should be there, like family history or ASCVD or hypertension or kidney disease should be there. And decision to initiate aspirin should be made after discussing about the bleeding risks. And if you see that, it has analyzed all the articles, and it will give you the detail in the summary in a very nutshell point at the end. So in summary, the current consensus in a diabetic patient, antiplatelet therapy is not recommended for all diabetic patients with primary prevention. So this is what, whenever you have a clinical doubt, you can ask. And most importantly, you can see the references. Almost all the references are given, and when you click on the references, that will direct you to the original article. For example, I clicked on this, then it is directed to the PubMed article. So now you should know the authenticity of the information which is given in this. Unlike in ChatGPT, where you may not know the reference, but here you may know the reference and you see whether this information is correct or not. So now coming to after finishing the two tools, now coming to the device, the diabetic retinopathy screening. This is the world's first smartphone-enabled non-mediatic camera with an with on-the-edge artificial intelligence. Actually, what is it? It's a device, handheld device, where you can screen the patient retina even without dilating it, and it provides a high-quality imaging and very portable, and it's designed for handheld use. And it has most important thing is it has an offline integrated AI algorithm. I'll show you. Actually, this is how you screen the patient eye with this. It has an inbuilt camera with iPhone, along with by which it takes the photo of the fundus, and then it analyzes. You can see here. See, even though there are changes in this fundus, you can see that the AI marks those changes, like where are the retinopathy changes are there, and then it gives you whether the patient has a clinically significant macular edema or a moderate NPDR, which is called as the referable diabetic retinopathy. So when you are sitting in your diabetic clinic, and you can't send every patient to screen for diabetic retinopathy, you can use this handheld device and you can screen it, and then it will generate a report immediately within 10 seconds with lesions are all marked. So it will be very easy for you to explain to the patient that these are all the area where you have lesions in the eye. And these are all the various images which are captured on the fundus on phone. You can see various types of retinopathy and severe NPDR, CSME, everything. So this is one of the reports which I used in my clinic. You can see that initially it marks the lesion. Actually, I'm not sure whether you are able to see there. In the right side, it marks the patient has significant signs of diabetic retinopathy screen, and it marks their areas it has been there. So now the validation is actually all trials and clinical endpoints included minimum mandated sensitivity and specificity. Almost it has 85% sensitivity and 82.5% specificity. It has been validated in various community centers, diabetes centers, in hospital setting, and the performance is comparable when run on desktop camera images. So I think that is the fundus camera. I asked them to bring it. It's a very handheld device which we can use it. It's very handheld. You can carry it very easily. You can use it, and you can just open this and ask the patient to see on this, and you get a mark in this, and you can usually usually train your staffs within 2 or 3 days, because it has a mark in that, and you have to just focus the optic disc on that mark, and that will capture the image and will give the report on the immediately. So take-home messages is AI can revolutionize diabetes care when critically used. Perplexity and open evidence are powerful evolving tools. Their integration into routine care improves speed and precision. but clinical judgment remains always irreplaceable. Because why I'm saying this is, when I uploaded, for example, when you don't give a proper prompt, for example, you say fever with cough and cold, it sometimes diagnoses the patient as melioidosis, which is very uncommon. So that is the most important thing. Clinical judgment always plays a major role when using these AI tools. Thank you.
Thank you, sir. Now we have seen about how we can use it in our clinical practice. I will request Dr. Shivakumar. He will be talking on how we can use it for research settings. So there is another spectrum. Now, as before Dr. Shivakumar takes over, like if you see, most of this AI app have come up with a free app as well as a paid app. So if you want to get the bigger results, say for example, if you want to use Perplexity, if you want the best results available in the market or best results available with the LLM, you should go for the paid version. But paid versions are all about costing about, it is about 2,000 rupees or so we have to pay from our packet. Most of us won't be willing. The one hack that we need to know is Airtel users who are all using, whether you use a prepaid or postpaid, Airtel has come out with a free plan. You have to go to Airtel Thanksgiving app. Over there is a section called as rewards. So once you do that, you can get it converted to a Perplexity free service for 1 year. Perplexity free is 1 year, and you can use it as paid service. Phenomenal. So that is something which have been made accessible to us. Most of you can use the paid service. Over to Dr. Shivakumar.
Thank you, Dr. Gauri Shankar, and thank you, RSSD Tamil Nadu chapter, for providing this wonderful opportunity to be here. And in the next 5 minutes, I am going to talk about this AI in clinical research. Generally, clinical research takes a back seat most of the time in our day-to-day clinical practice. In 2022, we had the first RSSDA research retreat conference where the focus was encouraging research amongst the RSSDA members. If some of you would have attended there, you might have learnt that we need so much of guidance to start a research in clinics. See, generally, most of the people who are getting updated each and every day, they have electronic health records in their clinics or hospitals, but they don't know how to use those clinical records for submitting a research paper. So, because of short of time, I am just going to deliver bird's eye view of how we can leverage technology, that is artificial intelligence, to start clinical research in our day-to-day clinical practice. So this is what going to be. I used AI tools to create, edit, and have this presentation. So what are the bottlenecks in traditional research? You know, extensively you have to read the articles. Every day you have to update. It contains a lot of jargons. And one of the reason most of us joined medicine is we hate mathematics, particularly statistics. While we have a mindset like this, it is really hard to do statistical analysis, you know, all those things. So CT, 2T test, then Z test, you know, these are all complex jargons. Then prolonged journey, you know, doing research is not so simple. There are so many missed opportunities too. But what are the advantages when we use artificial intelligence? Now, it's like a co-pilot. We can use this as a important assistant. See, whatever you read for so many hours, months, everything it can do summarization. Already previous speakers have told about how Perplexity as well as this ChatGPT can summarize everything in a nutshell, whichever the format we want, like maybe 100 words, it may be 500 words. If you want to publish, still you can do all those things. But the most important aspect is dynamic questioning. What kind of research are you going to do? Say for example, you have huge data in your clinic or hospital. How? Now the question is, say for example, I want to analyze what is the body mass index in our clinical population. Then this is the dynamic question. Then evidence retrieval. I am going to use some of the only couple of tools to show you how it can help to do all these things: evidence retrieval, then trial summaries, then drafting the assistance, and journal suggestions, because we need references even for publication, so for that we need journal suggestions. All those things can be done with the help of technology. So I have just shortlisted 5 things. The most important thing I am going to do here is elicit, and which is for literature review and evidence synthesis, and again ChatGPT Pro version does a lot thing. Day before yesterday it was GPT-5 version, GPT-5, where it has been trained with too many some 17 trillion data, and of course there are other things also. Say for example, how can we do the simple things, unraveling the complex cases? This is the what explains high insulin resistance in lean Indian diabetics under 30. This is the research question. So for which, if you go to the elicit.org, you can simply sign up. I don't want to explain everything in video because already we are running short of time. So you can elicit on your own through this website elicit.org, where you can sign up, then sign in and go and ask whatever the research question you want. It can give you summary of all the research articles. Of course you can see the entire research articles too. That is the importance. Now before going to why we are not doing research in our day-to-day clinical practice, it is really cumbersome. First you have to spend some time for whatever we are doing, and starting from ideation to questioning, then literature retrieval, data summarization, hypothesis formulation. Whether, say for example, you might have your own doubts. You might say that, see, in my clinical practice, what I need is 50-50 insulin. Most of my patients need 50-50 premix combo. If that is your research question, you can formulate research question like that. You can get evidence. If you don't have any evidence at all, then this is the hypothesis question. Then how you are going to prove or disprove that hypothesis question? This is very, very important. Then you draft your research. You say for example, whatever the patients you put in your day-to-day clinical practice, categorize what they are getting: basal bolus insulin, premix 30-70, premix 50-50. Then analyze the data. That data analysis part it can take care. That is ChatGPT. So of course there are too many other things like drug repurposing and hypothesis generation, gap analysis in RCTs, because see, we have so many RCTs. If you consider semaglutide, we have step trials, step 1, step 2, like that, so many trials. If you want to see all those data in a nutshell, it is possible with the help of ChatGPT. And of course you can have your own study design, which is very much personalized. Then so many other things. Of course இது வந்து ஒரு சால்ட் மாதிரி தான் சம்டைம்ஸ் எடுத்துக்கணும். சால்ட் இல்லைன்னா டேஸ்டே இருக்காது ஃபுட்டு. ஆனால் வந்து மேஜர் காம்பனன்ட் பார்த்தீங்கன்னா சால்ட் கிடையாது. இட்ஸ் அ வெரி ஸ்மால் குவான்டிட்டி. லைக் தட், if you use technology, that is artificial intelligence, properly like a salt, which will add flavor to your clinical research. And patient data security, of course you have to anonymize, you have to get ethics committee approval or IRB approval, all those things. Those are all very, very important. And once you do certain research, you can enhance your abstracts. You can simply co-write with the, it can co-write with you, and you just take and edit whatever you require for submission in an article. And of course if you want to collaborate, there is one more tool called as Zotero. And then finally you can structure your CME submission too. To summarize everything in a nutshell, besides if we want to build certain things, we need to do research. இப்போ நம்ம பேசுனது எல்லாமே வந்து யாரோ ஒரு ஃபாரினர் கண்டுபிடிச்சு அவங்க இங்கே கொண்டு வந்த பிறகு நம்ம அதை அப்ரிஷியேட் பண்ணி இதை யூஸ் பண்ணலாம், அதை யூஸ் பண்ணலாம் அப்படிங்கிறோம். எனிஹவ் வேறு வழி இல்லை, நமக்கு நம்ம ரிசர்ச் பண்ணுறதே இல்லை. ரிசர்ச் பண்ணாலும் வந்து நம்ம வேறு எங்கேயும் என்கரேஜ் பண்ணுறதில்ல. பட் அட்லீஸ்ட் இனிமே, because this can help to save a lot of time in your day-to-day clinical practice. You can do publication, submission, all those things that will add cap to your day-to-day clinical practice, also your reputation. So it will be very much precise, personalized approach is possible. Ultimately that translates into your better clinical care. Thank you very much. Thank you.
So, thank you, sir. So what we try to do is we try to show you two tools for each of the things, whether it is patient learning, self-education, patient education, or for your research purpose. But what we need to learn at the end of this session is it is all like cycle learning. We have to go find out the right app, ask for the right question, give the right prompt for the right solution. Unless like we practice, like it will not come. And we are here, like if you want to discuss, like we are always willing to take questions or we can discuss. So all that I request is, it is not possible for our life nowadays without this AI apps. So whether you type a message, whether you post a social media post, or whatever you do, you can always cross-check and correct your language, correct your content, all these things. So they are going to stay. It is better like we take up and use all these things in our day-to-day for every of those things. So with this I conclude. I thank all the panelists who have been with us. Thank you all. Thank you.
Thank you. Thank you all.
Thank you for the excellent artificial intelligence workshop. Now we go on to the next workshop because already we are 10 minutes late, and I call upon the moderator Dr. Muralidharan and the speakers Dr. Palnikumaran, Prakash and Balaji Sundaram on the stage, and your time is 9:30. Please finish with 9:30. இல்ல முடியாது, நான் ஸ்டாப் பண்ணிடுவேன், மைக்கெல்லாம் ஆஃப் பண்ணிடுவேன். 40 minutes முடிச்சிரோம் அவ்வளவுதான். 9:30 முடியணும்.
Good morning, friends. It gives me immense pleasure to be with you. All these 45 minutes we have been listening to artificial intelligence. This workshop, we need to use your natural intelligence, general knowledge, not to commit mistakes, to overcome the challenges. So, given time is 45 minutes, we should try to finish it within 40 minutes. The workshop, welcome to the workshop. Yeah, kudos to the organizing committee. This workshop is basically on insulin, and we are going to highlight the insulin injection techniques. We are not going to highlight the techniques, but what are the common mistakes our people commit during the insulin injection. We have got a panelist, Dr. Palnikumaran from Madurai Medical College, Dr. Balaji from Kumbakonam, Prakash from Salem Medical College. All these three legends in diabetology. They are very much interested in disseminating the knowledge. They have been doing it for so many years. Happy to welcome, happy to part of this wonderful workshop. Yeah. The common mistakes in the insulin injection, many people, they make at least one injection mistake, and most of our patients, they apply too much injection force. That is a cause for the mistakes. And we want to highlight one important point. Our patients, whether they use vials and syringes or pen devices, they commit a lot of mistakes. Those mistakes which lead to the likelihood of development of the serious adverse events, including hypoglycemia and uncontrolled HbA1c. And many patients, because of the wrong techniques, they develop pain, and the patient, they land up in the hypoglycemia, glycemic variability. When they develop pain, when they develop hypoglycemia, patient, they used to discontinue the insulin therapy. You will not get the treatment adherence or compliance. So we have to use the right insulin injection technique, and patient should know what is a site selection, how to rotate the site, everything. then only they can achieve the optimized insulin therapy, achieve the good glycemic control, and we can prevent the complications. Now, the time is limited to us. The next, Dr. Palani Kumaran and Prakash, they are going to highlight the classification of insulin and conventional insulins, analog insulin regimens. They take some 10 to 12 minutes, then we can go to the common mistakes.
Good morning, one and all. At the outside, I thank the organizing committee for giving us this opportunity. I thank our moderator, Dr. Muralidharan, who is a very busy diabetologist in Dendukal, unable even to attend our calls. Next, I have a happy with Dr. Balaji and Dr. Palani Kumaran. First of all, we want to highlight what are the different types of insulin as a duologue between me and Dr. Palani Kumaran. So first, we start with insulin. Insulin was discovered in the year 1921 and almost 100 years gone. And initially, it was on slaughtering animals because animal insulin at that time. Then it changed to genetic engineering technique insulin. It's called human insulin. Our Professor Hariharan sir used to say, it is not human insulin, it is humanoid insulin. So it was made not from humans, it is from genetic engineering technique. And the development of insulin is day by day increasing. Every year there is a launch of new vehicle, a new insulin. So similarly, we like to start with discussion. Dr. Palani Kumaran, who is my colleague, is working as assistant professor in medicine at Madurai Medical College. And Dr. Palani Kumaran, tell me the classification of insulin.
Thank you, Prakash, for asking this the basic question, and everybody knows that. So we can classify insulin according to the mode of action, actually duration of action. So we know that we do have different, two main classes. One is our conventional human insulins, and the recent one we do have our modern insulin, otherwise called insulin analogs. So this conventional, under conventional insulins, we do have three types according to the duration of action. So short-acting insulin, otherwise called regular insulin, simply we can say it as R. In brand name, any insulin with R, we can brand them as they are short-acting insulin. And the next one will be intermediate-acting insulin. They are the only intermediate-acting available is the NPH, that is neutral protamine H down. And simply we can name it as N. Any insulin vial with N, it is an NPH, it's an intermediate-acting insulin. And the next one will be the combination of short-acting plus intermediate at a fixed proportion. So pre-mixed human insulins. So it can be either 30/70 or 50/50. The first component will be R and the second component will be N. Coming to the insulin analogs, we do have rapid-acting insulin analogs such as Aspart, Lispro and Glulysin, and long-acting analogs like Glargine, Detimer, ultra-long-acting Degludec and Glargine U300, and pre-mixed analogs such as proteminated Aspart and proteminated Lispro, and pre-mixed co-formulations, that is a combination of Degludec plus Aspart, that is Idacasp. So these are all the insulins available in the market. So we have to play our insulin management with these type of insulins. Now over to Prakash. So what are the difference between the comparison of conventional and analog insulins?
Conventional insulin, we have short-acting insulin and intermediate-acting insulin, which we have been used for many years. Now we have designer insulin, modern insulin, it's called insulin analogs. The conventional insulin is, we have short-acting insulin, which has to be given half an hour before food. Why half an hour before food? Because it is in hexameric form. It has to get converted to monomer, then only it acts. So it takes a lag time of 30 to 45 minutes. So we can't give just before food. That is the disadvantage of conventional short-acting insulin. Now we have short-acting insulin analog, wherein it is already in monomeric form. It can be given just before food or immediately after food. So this is the advantage of short-acting insulin conventional and the present short-acting insulin analog. And then it has got a shorter duration of action. The conventional insulin has a duration of action of 8 to 12 hours. So hypoglycemia risks are more with conventional insulin, but with modern short-acting insulin analog, the duration of action is only 4 hours. For example, if we take food by 8 o'clock, we get hungry by 12 o'clock.
So, whereas the conventional insulin lag for longer period of time resulting in hypoglycemic risk, whereas with modern analogs, that risk is not there because the duration of action is only for 4 hours. And we have different mixtures of conventional insulin as well as insulin analogs. We have regular insulin with intermediate acting insulin combination, and we have similarly short acting insulin analog combined with long acting. So we have all sorts of mixtures with both modern and conventional insulin. So long acting insulin analogs, we have deximer, glargine and degludec. What is the advantage of old intermediate acting insulin, long acting analog is the good basal insulin should have 24 hours duration of action. So the conventional insulin has only 12 to 14 hours. So that is and another advantage of long acting analogs is there is peak-like plateau-like action. So there is less risk of hypoglycemia. So these are all the advantage of modern insulin and conventional insulin, and it mimics physiological insulin secretion, better time action profile, predictable action, superior postprandial reduction, more safety, less weight gain, and mealtime flexibility will be better with modern insulin, and is convenient use both in vials as well as in pens. Next, I invite Dr. Palnikumaran to talk on what are the insulin regimens that has to be followed in the management of diabetes.
So regarding insulin regimen, we should know some basic regimes which are commonly practically useful for our patients. The most common will be the basal only insulin regime, and this is ideally suitable for type 2 diabetic as a outpatient settings. So whenever a type 2 diabetic patient with the maximum OHA has gone for beta cell failure, so recurring insulinization, so in that case you can, along with the OAD, you can add this basal insulin. So this will cover, it can be given, if it is going to be NPH, it can be given in the night, or if it is going to be the true basal, that is insulin analog, it can be given even in the morning. Next. So next regime will be bolus insulin regimes. So this is, giving a bolus, that is short-acting insulin with each meal, before each meal, so that it will be covering the postprandial blood sugar surge. So this regime can be used at times, but it's not commonly used. Isolated bolus we are not commonly using. And next one is the basal plus. So by having a basal insulin, that is a long-acting or NPH insulin, you can add a prandial insulin, that is bolus short-acting insulin, whenever a particular meal, is causing an increased postprandial surge. So suppose morning breakfast alone is high, you can have a basal, along with you can add a prandial insulin in the morning time. That's called basal plus regime. And next regime will be basal bolus regime, and this is the ideal regime for type 1 diabetes and ideal regime for any type 2 DM being admitted in the hospital. And even type 2 DM difficult to control, you can go with this basal bolus. As the name indicates, there will be a basal coverage, that is long-acting insulin will be covering the intermeal blood glucose, and short-acting will be covering the postprandial glucose. So you have to give a 3 short-acting insulin shots, that is the prandial, short-acting insulin shots, and one basal. It can be either insulin analog or NPH. And next slide. Coming to the pre-mixed insulin, this is another regime. So we are already having a pre-mixed combination of regular and NPH. So this can be administered very easily, especially for type 2 DM. And it can be given as a, if it's going to be a conventional pre-mix, it can be given as a once daily or twice daily, depending upon the blood sugar status. And next, Prakash will say about.
Thank you. Since for want of time, we need to finish off. I like to thank Dr. Palnikumaran, and he had said the different regimens, basal bolus regimen, mixed split regimen and all. Basal bolus regimen has to be followed in all type 1 diabetes patient, in critically ill patient, hospitalized patient, and pre-mixed insulin, that is mixed split insulin, as an advantage in patient compliance that can be used in OP settings. Thank you.
Friends, well done, Dr. Prakash and Palnikumaran. Basics of insulin they have covered. Usually we need to minimum 2 hours for this workshop. We have been given 45 minutes, and again they have reduced to 30 minutes. So let us finish it another 14 minutes. Now, what are the practical aspects of insulin therapy? Dr. Sundaram sir and Hariharan sir and Shanmugal sir, they are pioneers in educating, disseminating the knowledge regarding the insulin. So our patients, they should use their general knowledge to overcome the challenges. Yeah. What will happen if the patient is injecting insulin into the muscle? We all know that insulin injection meant for subcutaneous. Injecting into the muscle is a mistake. So what will happen? Injecting insulin in the subcutaneous fat, stable, consistent absorption and predictable results. So it should be given in the subcutaneous. By mistake, injection is given into the as an intramuscular, accelerated absorption, risk of hypoglycemia. So we should avoid. So thin persons, low BMI, using the long needles, or they develop a risk of intramuscular injection. So we need to use 4 mm needle for the pen devices, 6 mm needle for the syringes. If you use the right insulin injection technique, by using these 4 mm, 6 mm needles, we can deliver the insulin in the subcutaneous fat, no risk of hypoglycemia. Balaji?
So, while we give the injection, sir will explain why to lift the skin for the injection and how to release the skin fold while the needle is inside the skin. So, ideally, we use the thumb and the index finger to use the skin fold. So, if we are not using it appropriately, the needle will not go particularly into the subcutaneous tissue. So for example, in those days we have been using the 6 mm and 8 mm needle were there. So if the skin fold is not approximately pinched, there is a risk of injecting the insulin into the deeper muscle, and the injection will be easily dissociated into the blood circulation, and the risk of hypoglycemia is very more. So that's why ideally the thumb and index finger should be used to lift the fold, and it can be possibly with the addition of the middle finger and use of the whole hand, as always the risk of injecting into the muscle. So that's the recommendation is the things. So next thing is why to clean and not injecting into the cleaner sites.
Yeah, simple thing. Injection should be given into the clean sites using the clean hands. Many of the nursing homes, clinics, GH, private clinics, our staff members, they do not clean the injection site. This we have to accept it. So injection should be given into the clean site using the clean hands. For which we have to use the alcohol swab. If it is not available, cotton ball dipped into the water. These soap-based detergents should not be used. Cetrimide should not be used. Balaji, next.
So for the insulin pen injections, releasing the thumb button while the needle is inside the skin. So we use, nowadays patients use the pen injections. The use of vial has been gone. So once the thumb button is pushed into the skin, the patient should keep the pressure until the entire injection is being given and the injection is being released, the needle is being released from the skin. Then only they have to stop the button of the pen. So if the button is released while the skin is inside the skin, the body fluid and the cells may be aspirated into the cartilage, and it can cause contamination and cause more infection to the things.
So well done, Balaji. Next one, Balaji has very clearly told, when you use the pen devices, inserting the needle, we have to keep the thumb button pushed in. The thumb button is pushed in. Ask the patient to keep pressure on the thumb button for 10 seconds. Why 10 seconds? Because to prevent the medication leakage after removing the needle, one. Number two, this gives you sufficient time for the injected insulin to spread out through the tissue plates and cause the tissue to expand and stretch. So we need to use, when we advise the patient initiate with the pen devices, we have to sit with the patient and educate all these things, then only you can get the optimized insulin therapy.
So next is the reuse of needle. So we come across this type of thing in our common practice. So just see how the new needle, the tip of the new needle, how it is, once, after using once, and after using twice, and after using 6 times. So patients often use the reuse needles in the syringes and pen. What happens is they use it for the convenience aspect. But if they use the needle for this thing, the cause of pain, bleeding, lipohypertrophy, sterility, and infection is very high. The thing is, the damage to the reused needles is actually high as they go deep into the rubber. For example, if they use the syringe needle repeatedly, they just inject into the rubber and take it. So the tip of the needle is becoming blunt more and more thing. The last thing is, if the needle is left in between the injections, the air can enter into the reservoir, into the pen, and affect the accuracy of the next dose of the things. So the entire multiple times if they use, the chances of the accuracy is less, and the cause of other infections and other thing is very, very high. So these are the various adverse effects if they use the needles repeatedly: pain, bleeding, contamination, and dosage inaccuracy, breaking off, and lipohypertrophy. The same thing.
Well done, Balaji. Needles, before 10 years, before the introduction of SETR guidelines, what is our practice is, many of you will accept, we used to tell the patient that use the needle until you get the pain. This was a practice in most of the cities. But using reuse of needles, lot of these issues, we have to tell the patient, according to the recommendation, single use. But in India, pen needle is around 18 to 19 rupees. Our patients are not affordable. For all practical purposes, we use the needle 2 to 3 times. Then we change it. This is not scientific message, but practical purpose we are using this. Yeah. This one, mixing the cloudy insulins, pre-mixed insulin, NPH insulin, we have to mix it, or resuspension should be done, but we are not doing it. Many of the places we are not doing it. What will happen? Inadequate resuspension can lead to varying concentrations of insulin, by which unpredictable results will come. So we have to resuspend, mix it. For which some patients, what they do is, they shake the vials vigorously. Vigorous shaking should not be done. Once we vigorously shake it, what will happen? Air bubbles will come, which will prevent the flow of the insulin. Adequacy, that is accuracy of the dose, will be lost. So resuspension, how will you ensure it? You roll it between the 2 palms or dip it for 10 times. The insulin crystals will get dissolved and mixed up uniformly. Once a solution becomes milky white, you can ensure that it is properly mixed.
So next thing is injecting into the same site once again. So site rotation has to be taught to each and every patient. Most important thing is, so we know what are the regions of injecting into the thing: the thighs, the forearm, and the abdomen. So repeated injection into the same site always have the risk of infection. So one thing is, advise the patient to rotate the sites once in a week. So ask the patient to particularly focus on one quadrant in a single week, then in a clockwise direction, and then go to the next quadrant, and after week likewise they have to rotate. So this diagram clearly depicts how to rotate the sites. For example, if you just take about the abdomen, to start from the left side of the abdomen and go in a clockwise direction in a single quadrant. So this diagram rotating within the same side. For example, if they just focus upon the upper lateral quadrant or upper left quadrant, the site should be rotated each and every time. So this is the way how to rotate the site rotation. So this thing is will avoid the risk of carrying lipoatrophy and other type of adverse
Well done,
effects.
Balaji. We have to tell our patients, ask the patient, first you ask your staff members to inspect the site, injection site. Every visit, we don't find time, we tell our dietitian, educator, check the site, then only it is good. And also educate the patient for self-inspection for any abrasion or wound or lipohypertrophy, all those things. Yeah, injecting into the LH site, it is wrong. We have to inject into the healthy site. So people, you are using insulin for long duration, not rotating the injection site, reuse of needles, the problem of developing LH, lipohypertrophy. What is the problem if you inject into the LH site? If you inject into the LH area, patient will use to develop unexplained hypoglycemia. One, glycemic variability 2, sometimes hyperglycemia. Why patient they tend to give the injection into the LH site? Because it is painless. So patient tend to use the same site again and again. We have to avoid. Then tell the patient switch over to normal site. When you switch over to normal site from LH site, there is a possibility of developing hypoglycemia. So tell the patient reduce the dose of insulin, monitor with the glucose monitoring, then it is easy for you to do it. So you have to avoid injecting into the LH site because of all these reasons.
So next thing is whether we can share the pen and the syringe. So always advise it can be used only for a single person, even it may be a wife or a dearer one. It should never be shared with anyone. So we can share any other things, but the insulin syringe and pen should not be shared even with your partners and wives. So that's the thing we have to explain and educate to all our patients. So next.
Lover இருந்தாலும் girlfriend இருந்தாலும் யூஸ் பண்ண கூடாது, ஷேர் பண்ண கூடாது. So again inject into the same site. Although we told LH lipohypertrophy, இன்னொரு problem உள்ளது lipoatrophy. Lipoatrophy is now uncommon because of the usage of purified insulin and analog insulin. But we should know visible cutaneous depression at the site of injection and palpable atrophy will be there. Every time we have to inspect both LH and lipoatrophy. Please.
Next thing is the leaking from the pen. So the leakage is usually due to the poor seal between the needle and cartridge. So reflux or backflow out of the injection site may happen when the needle is just taken out too soon. So which I told you before. The last thing is use the needles that have a wider inner diameter and improved insulin flow. So one thing is always just look for any leakage before injecting any insulin, because the dosage and other things can be differed when you use a pen or a syringe with some leakage and other things.
Now extra thin wall needles are available. The impact of people they have come out with 32 gauge 4 mm needles is available. It is highly wonderful, improved insulin flow, so there will not be any leakage, all those things. Education is very, very important. This entire workshop, entire 2 days Trac2025 is for disseminating the knowledge. All our teachers sitting in front of us, they have been keep on telling us, educating us, disseminating the knowledge. Any new therapy or insulin therapy initiation, patients usually they are very anxious. You know, Usi Vana sir, Usi Vandam. We have to educate, we have to highlight the importance of benefits of the insulin therapy, everything. We have to address their anxiety, we should show empathy, everything. அதுக்கு என்ன செய்யணும், இன்சுலினை கையில் எடுத்து வந்து ஒரு ட்ரை இன்ஜெக்ஷன் நம்ம போட்டு காட்டணும். தென் பேஷண்ட்டை கொடுத்து நீ போடுவாங்கணும். அவங்க போட்டதுக்கு பின்னாடி they will say that I am so much comfortable. Once they are comfortable only when we show these 4 mm, 6 mm needles, syringe and pen devices, then they see, ஓஹோ இவ்வளோ சின்ன நீடிலா, இவ்வளோ கம்ஃபர்டபுளாக இருக்கா, அதை அவங்க அனலைஸ் ரியலைஸ் பண்ணால் மட்டும்தான் there will be improved treatment adherence and compliance. Then only we can achieve the optimized insulin therapy, we can achieve the glycemic control, we can prevent the complications.
So next thing is about the storage. So always advise the patients to keep the insulin in the optimum room temperature. So never ask the patients to keep the insulin in the freezer. So நம்ம எல்லாரும் என்ன சொல்லுவாங்கன்னா எப்போதும் ரூம் டெம்பரேச்சர்னு சொல்றது புரிஞ்சுக்க மாட்டாங்க. இன்சுலின் அப்படின்னா ரொம்ப கூலாக வச்சுக்கணும் அப்படின்னு சொல்லிட்டு patient, most of the patient they keep it in the freezer. So we have to just say if you keep the insulin in the freezer, there is always the risk of freezing. So we can advise them to keep the insulin inside the refrigerator and also not to keep them in the doors of the refrigerator. Sir, ஏன் சார் டோரில் வைக்கக்கூடாது அப்படின்னா 10 தடவை உங்கள் வீட்டில் உள்ளவங்க ஒவ்வொருத்தரையும் அந்த டோரை திறந்து யூஸ் பண்ணும்போது the temperature which is being maintained in the door will be less when compared to the temperature which is being maintained inside the compartment. So always advise the patients to maintain the temperature when we use the insulin syringes and pens.
Wonderful. அதுவும் முதல் தடவை எடுக்கலாம், அன்யூஸ்டு இன்சுலின் வயால உள்ள வைக்கலாம், யூஸ் பண்ண ஆரம்பிச்ச பிறகு எகைன் உள்ள வைக்கக்கூடாது. அப்போ என்ன செய்யணும், we have to maintain in the store it in the optimum temperature of 15 to 30 degrees Celsius. இப்போ என்னன்னா ஃப்ரிட்ஜ் மேலே வைக்கக்கூடாது, கிச்சனில் வைக்கக்கூடாது, சூடான இடத்துல வைக்கக்கூடாது, காரில் வந்து டேஷ்போர்டில் வைக்கக்கூடாது. வீட்டில் வேறு எங்கே வைக்கலாம்னா உள் ரூமில் ஜன்னலில் வைக்கலாம், வெயில் படாத இடத்துல. அல்லது இந்த மாதிரி கிளே பாட் வாங்கிட்டு அதில் உள்ள வந்து இந்த கவரில் இந்த மாதிரி உள்ளே போட்டு வைக்கலாம். அல்லது டபுள் கிளே பாட், சின்ன பாட்டு பெரிய பாட்டு உள்ளே வச்சு சாண்டை போட்டு தண்ணி ஊற்றியாச்சுன்னா வாட்டர் வில் எவாபரேட், ஹீட் வில் பி புல்லிங் அவுட், அது மெயின்டைன் ஆகும். இது வந்து ஒவ்வொரு மேன்ஸ் ரெஃப்ரிஜரேட். ஸோ டைம் வந்து 5 minutes இருக்கா? தென் குயிக்காக மற்றதை பண்ணிடலாம். இதில் டெமோவில் வந்து காமன் ப்ராப்ளம் அவர் பேஷண்ட்ஸ் பண்ணுறது வந்து இன்சுலின் சிரிஞ்ச் எடுத்துட்டு ஆல்கஹால் அப்ளை பண்ணுவாங்க. ஆல்கஹால் அப்ளை பண்ணால் சிலிக்கான் கோட்டிங் வில் பி லாஸ்ட், லூப்ரிகேஷன் போயிடும். அதனால வந்து அதை யூஸ் பண்ணக்கூடாது. இன்ஜெக்ஷனை ஃப்ரிட்ஜில் வெளியே எடுத்தது உடனேயே வந்து நம்ம போடக்கூடாது. கோல்டு வெர்ஷன் ஆஃப் இன்சுலின் வில் லீட் டு கிரையோ ட்ராமா. ஆல்சோ இட் இஸ் காசிங் த ரிஸ்க் ஆஃப் லைப்போ ஹைப்பர்ட்ராஃபி. ரீசன்ட் ஸ்டடி தே ஹவ் ஷோன் தட் பெயின்ஃபுல்லாக இருக்கும். அதனால வந்து we should allow the insulin to come to the normal room temperature. அடுத்து இன்சுலின் நம்ம ஆல்கஹால் அப்ளை பண்ணதுக்கு அப்புறம் உடனே இன்ஜெக்ஷன் போடக்கூடாது. மினிமம் 5 to 10 செகண்ட் வெயிட் பண்ணி we allow the alcohol to evaporate and the skin becomes dry. otherwise என்ன ஆகும்னா வந்து மைக்ரோ பபிள்ஸ் ஆஃப் ஆல்கஹால் உள்ள போய் இரிட்டேட் ஆகும். we should not do it.
Next thing is always never advise the patient to use the insulin through the clothing. So because this practice, the needle may become unsterile. Secondly, it can cause infection. Thirdly, the lubrication may be lost, potentially causing pain, and the clothing fibers may enter and irritate the skin. So என்னைக்குமே இன்சுலின் போடும்போது பேஷண்ட்டை முக்கியமான விஷயம் என்ன சொன்னா, இந்த துணிக்கு மேலே போடவே கூடாது. So it carries all type of adverse effects in using the insulin.
அது மட்டும் இல்லாமல் விஷுவலைஸ் பண்ண முடியாது. அதே சமயத்தில் வந்து நம்ம when you use a syringe நம்ம வந்து ஸ்கின் ஃபோல்டு லிஃப்ட் அப் பண்ண முடியாது. ஸோ ஸ்கின் மேலே துணிக்கு மேலே போடக்கூடாது. பல பேஷண்ட்ஸ் என்ன செய்கிறாங்கன்னா இன்ஜெக்ஷனை புஷ் பண்ணிவிட்டு பெண்ணை வந்து டயல் பண்ணிடுறாங்க. டயல் பண்ணிவிட்டு இன்ஜெக்ட் பண்ணாமல் தம் பட்டனை புஷ் பண்ணாமல் டயல் பேக். அப்படி பண்ணும்போது என்ன நினைக்கிறாங்க, இன்சுலின் இஸ் டெலிவர்டுன்னு நினைக்கிறாங்க. பட் ஒரு சொட்டு கூட உள்ளே போகாது. அதை நம்ம யூ ஹேவ் டு டீச். டிப்ரெஷன் வந்து கரெக்டாக டிப்ரெஸ் பண்ணணும், 10 செகண்ட் வெயிட் பண்ணணும், அதர்வைஸ் டெலிவரி ஃபுல்லாக ஆகாது. இந்த மாதிரி இன்சுலின்ஸை நம்ம பார்த்தோம்னா வி ஷுட் டிஸ்கார்ட் இட். பல கிளினிக்கில் போய் பார்க்குறோம், இது இப்படி தான் யூஸ் பண்ணுறாங்க. அது டாக்டர்ஸ் அதை பார்க்குறது கிடையாது. ஸ்டாஃப் மெம்பர்ஸ் தே டோன்ட் இன்ஃபார்ம் டு த டாக்டர்ஸ். இந்த மாதிரி யூஸ் பண்ணும்போது வந்து பொட்டன்சி இருக்காது, சிக்கல் வந்துடும்.
So lastly, the mismatching about the things, everyone know about the thing, but Indian standards, in those days we used only 40 IU. Now the risk of both 40 and 100 IU syringes come. So never use in a different aspect 40 IU vial with a 100 IU syringe. So to avoid mismatching, they have come up with two colors. One with an orange cap, that is 100 IU, and the red cap with 40 IU. So in the color coding should be teach to the patients, and அவங்கள்ட்ட தெளிவா சொல்லி கொடுக்கணும். The 40 IU bottle எடுக்கறாங்க அப்படினா the 40 IU syringe தான் யூஸ் பண்ணணும். இல்ல அப்படினா the risk of hypoglycemia is very very high, as the dose calculating will be different.
Okay. 1 minute, final 1 minute. பல பேஷண்ட்ஸ் என்ன செய்றாங்கன்னா பென் டிவைஸ் பெண்ணை வாங்காம கார்ட்ரேஜ் மட்டும் வாங்கிடுறாங்க. பல கம்பெனிஸ் வந்து இப்போ பென் வந்து ஃப்ரீயாக கொடுக்குறாங்க. சம்டைம்ஸ் சில கிளினிக்கில் அந்த ஃப்ரீ பென் கிடைக்காம என்ன செய்கிறாங்கன்னா அந்த பென் கார்ட்ரேஜை வாங்கி வச்சிடுறாங்க. பேஷண்ட் என்ன செய்கிறாங்கன்னா பெண்ணு வந்து 750 ரூபா 500 ரூபான்னு சொன்னாங்கன்னா பெண்ணை வாங்காமல் கார்ட்ரேஜை வாங்கிட்டு சிரிஞ்ச் எடுத்து யூஸ் பண்ணுறாங்க. தே ஷுட் பி டிஸ்கரேஜ். இது மாதிரி இன்னும் லாட் ஆஃப் காமன் மிஸ்டேக்ஸ் இருக்குது. பட் டைம் இஸ் வெரி ஷார்ட். முடிச்சிடலாம். ஸோ தேங்க்யூ வெரி மச் for the opportunity given to us, and thank you Dr. Prakash, Dr. Kumaran, Dr. Balaji for this wonderful presentation. Thanks a lot.
Thank you, the chair and the co-speakers for a wonderful session on the workshop on insulin, making it very easy for our day-to-day practice. Next, we invite for a thematic symposium, Chairperson Sivanganam, Dr. Pichumani, and Dr. Ganeshan to the dais.
And I call upon the speakers, Dr. Vengo Prasad sir, Joseph Panneerselvam sir, and Aarti Kannan sir for the next upcoming session. Vengo Prasad sir, he is the consultant of Abhirami Hospital, and he is the HOD of Department of Diabetology in Coimbatore Medical College. He did his MD General Medicine in Coimbatore and Diabetology in Madras Medical College. So, go ahead, sir.
Thank you, dear chairpersons. Very good morning. So, it's a great privilege to be here in this Trac 2025 Coimbatore, and it's still a greater privilege because I am given a topic that is extremely innovative. Now, I have two statements to make. One, they always give me the first talk after a gala dinner. And number two, they always give me a talk that is little very difficult to search for. So this time, this is intergenerational transfer of metabolic memory. So before starting this, I would like to give a small tidbit of medicine and praise ourselves. We all know that only half of the people lived till the age of 30 when we were cavemen. In the 1840s to 1900s also, the half-life of men or mankind was only 35. But only after the advent of this modern medicine, now not even a single baby is allowed to die until he becomes an elderly. So this is because of the major advancement of modern medicine, not exactly like what others now promote. Cavemen ate organic, breathed organic, drank only pure water. But in today's life, we have everything polluted and we still live on. So let us take the credit to the medical fraternity that we are doing a wonderful job in saving the mankind in spite of all the disadvantages. So what could be the reason? So there has to be something that has been passing on from one generation to another. So I am going to promote the idea. Don't feel guilty if you are a diabetic today, if you are overeating. Pass the blame on your grandparents. So this is the concept of intergenerational transfer of metabolic memory. So my agenda is like definition, mechanisms, implication, and prevention. So basically there are three concepts here. One is the metabolic memory that we have, all of us know. It is like the legacy effect. A person with any metabolic abnormality, when treated early on, and if he loses follow-up, the early good treatment still carries on with a better prognosis when compared to a person who has never been treated at all. And the corollary is the patient has been not treated early on and it still progresses, that the patient will have poor prognosis later on when compared to a person who has been treated regularly. So next comes the intergenerational memory. This is any metabolic abnormality in a parent poses a high risk of the same metabolic or another metabolic disorder in the offspring. So this is intergenerational memory. And the third one is the transgenerational memory. Here, metabolic abnormality or any poor metabolic situation or abnormal metabolic situation in the grandparents can be passed on to the grandsons and so on. So how does this happen? And this is what we are supposed to see. And do we have any evidences for this? There have been so many studies that tell us that the metabolic traits and risks can pass on from parents to sibling without changes to the underlying DNA sequence. So how can this happen? And what are the evidences behind this? So one, we all know that the Barker's hypothesis, often spoken on, it tells us that when the mother is undernourished, the offspring can have a high risk for metabolic abnormality like obesity or diabetes mellitus, basically because of the thrifty gene hypothesis. Because when the fetus is exposed to low nutrition when in womb, it develops the capability to store the energy, but after a while when the fetus becomes an adult, is exposed to excess nutrition or even normal nutrition, they are not able to tackle the overnutrition by burning excess fuel, but it tries to still store on, leading to the malnourishment. So this is basically all the first 4 or 5 studies that I have posted are basically on the mothers. And further, these are those Barker's hypothesis and thrifty gene studies were basically hypothesis, and those were like further substantiated with a few studies, like the Dutch hunger winter study. Here, in Dutch hunger winter study, it was a study that was undertaken in the in Netherlands, where grandparents who were it's one of the famous influential studies. This was done in the famine periods of the Dutch between 1944 and 1945. The individuals whose mothers were exposed to famine during the early stages of pregnancy had a higher risk of developing obesity, cardiovascular disease, abnormal glucose metabolism in adulthood, and more remarkably, their children, that is the grandparents, who were not directly exposed to the famine in any way, also showed risk of increased risk of obesity and altered metabolic profile. And this was also substantiated by an overcalic study. This was also done in the Scandinavian population, the same kind of study. And then the Pima Indian population. This is little interesting, because we all know that they are predisposed to high rates of type 2 diabetes mellitus. The researchers observed that the offspring of the women with diabetes during pregnancy had a significantly higher risk of developing diabetes themselves. But the interesting point to note here is, the same mother, when she delivered a child before she became a diabetic, had that offspring to be healthy. But the child that she born after she became diabetic had a higher risk of diabetes mellitus. So here we have to note that any metabolic abnormality during the period or the process of conception can be highly influential. If it was basically a genetic problem, this is not the possibility. A baby born to the mother before she developing diabetes or after she developing diabetes would have had the same risk of developing diabetes, but it is entirely different. Not only this, Also, there are problems with the fathers, like the studies on the father. There are basically two studies that were done on the animal models, wherein it was seen that the researchers bred the male mice with healthy food and the fat and high fat diet, and they were mated with non-obese females, and they analyzed the metabolic health of the offspring, and it was found that consistently found that the offspring of a high fat diet fed fathers had an increased risk of diabetes and obesity. So these are also very clear evidences that paternal influence on the baby is also as an important factor during conception. And this is a human study, this is an ongoing study wherein the research focuses on the molecular changes in sperm from the obese patients before and after intervention like bariatric surgery. So they found that the obese men have a different DNA methylation pattern. So I'll come to the DNA methylation later on, and non-coding RNA profiles in their sperm compared to the lean men. Furthermore, after the bariatric surgery, which leads to a significant weight loss, many epigenetic changes were reversed. So this also tells that there is passing on of the metabolic situation to the offspring at the point of conception. So taking these three into account, we will have to decide that there need not be a purely genetic transmission. So there has to be some other mechanism by which the risks of the metabolic abnormality in the parent or grandparent will be transferred to the a grandson or a son. So what could be the mechanism? The mechanism is basically germline epigenetic modification and the in utero environment. In utero environment, we all know that when a fetus is subjected to a harsh environmental metabolic situation, the fetal stands to have the metabolism, a metabolic abnormality when it grows up. But epigenetics is one of the most important topics now, and of course this is going to be the future of medicine, wherein most of the ailments, especially the metabolic abnormalities, can be treated even before conception. So what is epigenetics? Epigenetics is something that happens on the gene during the situation, an abnormal situation or a normal situation. So in these conditions, the gene is not altered, but only the expression of the gene is altered. There is a temporary alteration in the gene that is passed on to the offspring. And most importantly, if it happens during the conception period or just pre-conception period, so there is a big problem. So how does it happen? There are three mechanisms. The DNA methylation. So DNA methylation is methylation of the DNA segments. So methylation of any DNA segment can cause or can silence that particular DNA transcription, or it can express more. So it depends on what part of the DNA is methylated, and thereby these things can alter the expression of the gene in both the mother and the fetus. Next is the histone modification. Histone, because we can understand what happens in the mother, can be passed on to fetus. But what happens to the father? How can it pass on to the fetus? So this epigenetics is one of the major explanations. Epigenetics to the gametes or the sperm to the father can do this. So histone, we all know that histone is a protein over which the DNA is tightly coiled. In each cell, only that particular part of DNA that has to be expressed will be little loose and it will be open for the transcription. But this histone modification, due to the various transcription factors, can cause an abnormal gene in an abnormal place to express. So this is even used nowadays in the treatment. And then comes the small RNA. We all know that small RNA have been already used in treatment. We we all know that inclisiran is one of the molecules that targets the PCSK9 receptors, and they are used for treating statin resistant dyslipidemia. So what is the small RNA? Small RNA molecules, they don't code for proteins, and these proteins play a role in regulating the gene expression. So research suggests that the parent's metabolic state can alter the non-coding RNA content of the sperm and the eggs, transmitting the information to the embryo. So now we do understand that even at temporary, there is 1 minute.
1 minute more. Sir.
1 minute.
1 minute more.
So the implications of such transmissions is like family history. In future, taking the family history shouldn't stop with just ancestral father or grandfather. It has to take into account the entire ancestral environment too. So just having diabetes in father or grandfather is not enough. A non-diabetic grandfather exposed to a famine or overeating could be a risk here. So we will have to be very clear in taking that history also. And of course, we have been very diligent in treating the GDM or whatever it is, metabolic abnormality in the mother. Now we will have to prepone it while planning the pregnancy itself. So these epigenetic, that's it sir, finished sir. So these epigenetic interventions can mitigate the disease. The future is epigenetic modification, sRNA biomarker discovery, and of course ethical framing. So what is the take home message? So if you are ill, don't feel guilty, blame your grandpa. And of course, if you don't want your offsprings or your grandsons to be ill, try to get your children married before they develop any metabolic abnormalities. So get them married early.
Thank you, Dr. Vengo sir.
Thank you,
for your nice presentation and very new informations and insight into this very good but different and unusual topic. Next, I call upon Dr. Joseph Panneerselvam sir, diabetologist from Trichy, and he is going to talk on metabolic surgeries. Sir, your time is 13 minutes plus 2.
Thank you. A very good morning, one and all. At the outset, I would like to thank the organizing team of Trac2025 and Balamurugan sir for giving me the opportunity. So my topic is metabolic surgery. As we all know, so the metabolic, so the obesity is and related type 2 diabetes and other disorders, they are increasing in a pandemic proportion. So we have medical management of obesity and these disorders, but they are not adequate to address the complications. So now the focus is shifted to metabolic surgery. Actually, it's not a new concept. So these surgeries have been started in 1960s itself. So we are going to discuss. So I'm going to discuss about this metabolic surgery. What's the role of metabolic surgery in treating obesity and related metabolic conditions? This is all the agenda. So the obesity and type 2 DM, they go in hand in hand. So metabolic surgery is an important option to achieve substantial and durable weight loss, because the medical management may not be able to bring about desired weight loss. So the substantial and durable weight loss is possible with the metabolic surgery. So the mechanism seems to extend beyond weight loss, and reduction in CV risk factors translates to better outcome if we go for metabolic surgery. And what is metabolic surgery? So these are the range of procedures that modify the stomach or small intestine to either restrict food intake or reduce nutrient absorption, or both. These are the very important mechanisms. Either they have to restrict the procedure, they have to restrict the food intake or reduce the nutrient absorption from the duodenum, or some of the procedures they provide both. Lead to significant weight loss and improvements in metabolic conditions like type 2 DM, hypertension, obesity, and sleep apnea and other related disorders. So the pathophysiology of obesity is very complex. So the many factors they contribute to the development of obesity, like environment, epigenetic, genetic, physiologic, socio-cultural, and so many factors are responsible for the development of obesity. So the obesity is graded by using body mass index. So the normal BMI is 18.5 to 25, and overweight 25 to 30, and class 1 30 to 34, 34.9. Class 2 obesity is 35 to 40. Any BMI more than 40 is classified as morbid obesity or class 3 obesity. These metabolic surgeries, they play a very important role in the last two categories. So either morbid obesity or patients with class 2 obesity with comorbid conditions. So these are all the obesity associated conditions. So the type 2 DM, hypertension, dyslipidemia, obstructive sleep apnea, arthritis, GERD, non-alcoholic fatty liver disease, PCOS, and clinical depression and functional impairment. These are all the conditions associated with obesity. And it can produce variety of complications from head to foot. So all the systems are involved. So with the obesity, so we have to find ways to control this obesity to prevent these complications. And we have medical management. So variety of drugs are available for the treatment of obesity, but they are not adequate. So these are some of the limitations. So the weight loss is only the modest. So only we can achieve modest weight loss, and often it is not durable. Whenever the patient stops the medications, there will be rebound increase in the weight. So the drug intolerance adverse effects also one of the reasons for the non-compliance from the patient side, because we have many drugs starting from orlistat and this phentermine, and recently GLP-1 receptor agonist also they are using for weight loss. But the drug intolerance is a major issue, like GI disturbances can occur, patient can have diarrhea and bloating abdomen. All these things, that the complaints be decreased from the patient side. So they have got different efficacy and safety profiles. No general treatment algorithm is available, because the treatment should be individualized. For each patient will require different treatment approach. These are some of the limitations of medical management. And what are the benefits of metabolic surgery? So it provides significant and greater weight loss. So up to even 50 to, we can achieve 50 to 60 kg weight loss also maximum. And it improves diabetes control, and it can achieve remission in majority of the diabetic patients after metabolic surgery. So many patients, so they remain free from diabetes. So remission can be achieved, and there will be improvements in other obesity and related conditions such as hypertension, and even the cancer incidence also will come down significantly. So the patient will have better quality of life, and the sense of well-being, physical well-being will be there after metabolic surgery. And what's the rationale for metabolic surgery? So due to the tendency for basal metabolic rate to decrease with the dieting, most people will regain all their weight returning to the previous homeostatic set point. This is the problem with medical management. Whenever we perform metabolic surgery, it appears to alter this mechanism and reset this point. So the points will be reset with a 15 to 20% of weight loss and maintenance up to 20 years. So the weight loss is durable over the period of 20 years. This leads to long-term survival benefit and improves obesity-related diseases and quality in life. And there are various mechanisms. So for this metabolic surgery, so it extends beyond weight loss. It's not only weight loss. So it is, the benefits are beyond weight loss. It causes depletion of liver fat and subsequent improvements in the hepatic insulin sensitivity and clearance. There will be very good improvement in the insulin sensitivity. So the improved incretin levels is another factor responsible for the better outcome, and the changes in the inflammatory and adipokine profiles also noted. This is the flow chart. So after performing metabolic surgery, it causes, so the patient will take decreased calories and increased ileal nutrient delivery instead of duodenum. So there will be malabsorption, and there will be increase in bile acids, and gut microbiota also improved. So the ultimate results are decrease in weight, increase in incretins, and decrease in insulin resistance, and increase in insulin secretion. Ultimately, it causes diabetes remission or improvement, and so the final result is decreased cardiovascular events and decreased mortality. So this is what are the inclusion criteria. So the patients, you have to select the patients correctly for better outcome. The age should be between 18 and 60 years, and body mass index should be more than 40. That means morbid obesity, and the patient's BMI of more than 35 with the significant comorbidities such as heart disease, diabetic hypertension, sleep apnea, and so on. And there's we can consider metabolic surgery if the patients with the BMI of between 30 and 35, if their diabetes is poorly controlled with the available means. The history of prior weight management attempts and motivation and engagement in lifestyle modification. So we can select these patients from this category. And what are the exclusion criteria? So patients already having cardiopulmonary disease and current usage of illicit drugs, tobacco use, and alcohol use patients should be excluded from this treatment. And lack of comprehension, reversible endocrine disorders with obesity, because it's a reversible cause, we need not do complex metabolic surgery in this group. So uncontrolled severe psychiatric illness is also a contraindication. And this is algorithm how to select the treatment option for patients with obesity. So we have to divide based on the BMI. If the patient's BMI is less than 30, so we can go for non-surgical management. If it is more than 30, so we have to divide whether it is class 1, class 2, and class 3. So class 3 patients, straight away we can recommend metabolic surgery. And class 2 patients, if the lifestyle management and medical management is not sufficient, so we can recommend metabolic surgery. And in patients with the class 2 and class 1 obesity with the poor glycemic control, we can consider doing metabolic surgery. This is algorithmic approach. And what are the surgical options available? So we have 3 mechanisms by which the surgical procedures work. One is restrictive procedures. That means we are restricting the intake of the so by restricting the capacity of the stomach, by performing sleeve gastrectomy and gastric band surgery and vertical band gastroplasty. And malabsorptive procedures, the bypass, jejunal-ileal bypass will be done to bypass the duodenum. It prevents the absorption and causes malnutrition. That way it improves the weight loss. So some of the procedures, so they provide both restrictive and malabsorptive. The examples are Roux-en-Y gastric bypass surgery, duodenal switch surgery, and sleeve bipartition. We'll discuss one by one. So this is a Roux-en-Y gastric bypass surgery. It started way back in the year 1960s. So here they will construct a small pouch in the proximal stomach, and they will connect it to the distal jejunum by bypassing duodenum and proximal jejunum. So thereby it causes both restriction of intake as well as the absorption defect. Thereby it works very well. So it provides a greater weight loss up to 60 to 80%, and changes in the gut hormones that reduce appetite and enhance satiety, and typical maintenance of more than 50% excess weight loss. The disadvantages are the procedure is very complex, and it can produce vitamin and mineral deficiencies. It requires longer hospital stay, and some of the patients they can develop internal hernias also. The next one is sleeve gastrectomy. Here along the lesser curvature, so they will resect the greater curvature. 70 to 80% of the stomach is resected. The remaining part of the stomach will form as a sleeve. So it's a very small portion. So there will be restricted intake, and there won't be any malabsorption here. Only the intake will be restricted. This procedure also started in 1960. Here also the significant weight loss can be achieved. So the hospital stay is shorter, and it changes the gut hormones to improve the satiety. So it will reset this neurohormonal mechanism, thereby it improves the satiety and causes weight loss. So disadvantage is a non-reversible procedure because the greater curvature of the stomach is resected, so it cannot be reversed. And again it can produce vitamin deficiency, there will be leak, and potential weight regain also is there. It's a disadvantage. And the third one is the duodenal switch. Here also they will perform the jejunal-ileal bypass to bypass the nutrition absorption from the duodenum. And again it provides greater weight loss, and this allows patient to eat near normal meal because the stomach capacity is not restricted. Disadvantages are has higher complication rates and the risk of mortality. It requires longer hospital stay. It's a complex surgery. And this one, next one is vertical band gastroplasty. Again, so they form as a pouch, small pouch, by stapling the stomach in the proximal portion. thereby their intake will be restricted, and so there will be restricted caloric intake, and it provides weight loss by this mechanism. So the last one is adjustable elastic gastric band. It's a very simple procedure. So they will fix a band in the proximal stomach to restrict the stomach quantity, and the port placed under the skin. So we can adjust, we can inflate the pump. So by injecting saline, so it can be inflated or deflated. So by this mechanism, the stomach capacity is restricted. So there will be decreased intake and ultimate weight loss. So what are the clinical trials data to support? So this is a 5-year, they have studied, in this trial they have studied 5-year changes in body weight and the rates of diabetic remission and changes in glycated hemoglobin. The first one is changes in body weight. So it's a greater weight loss achieved.
Joseph sir, yes. Kindly finish it in another one more.
Okay. So the next one is the diabetic remission. Remission at the end of 5 years is very much greater in patients, those who are undergoing this procedure. And the changes in glycated hemoglobin also is significant by this procedures compared to the medical management. And what are the complications? So there can be general complications like sepsis, bleeding, cardiopulmonary, and death also. The rate of death should be very, very low in the appropriate setup. These are the potential complications associated with this specific type of this surgery, like strictures, band erosion, gallstone formation is very important, side effects in all these procedures, and gastrogastric fistula and marginal ulcer, nutrition deficiencies, all these things can occur. We should be aware of this and provide the adequate nutritional supplement after the surgery. And what are the results? So the mean ratio of patients to the resolution of the type 2 diabetic remission can be achieved 48% with the gastric banding, and vertical band gastroplasty 68%. The maximum of 98% remission can be achieved with this duodenal switch surgery. And we can achieve the non-glycemic effects also. So the there will be improvement in hyperlipidemia and hypertension. So these are the take-home messages. So when the behavioral and the pharmacology interventions fail to manage, we can consider bariatric surgery, and the careful patient selection is very much important for the better outcome and to prevent the complications. Those is bypass techniques improves glucose homeostasis through mechanisms beyond reduced caloric intake and weight loss. So thank you for the patient listening.
Well, thank you, Dr. Joseph, for a good talk. Let me call upon Dr. Arthikannan, who is going to talk on polypharmacy. And I think the polypharmacy has become mandatory nowadays, and we cannot avoid it. Of course, with the advent of AI, in a few years' time or in a few months' time, the patients will be sitting in front of us talking about drug interactions and so on. We should be prepared for that. Let's see what Arthikannan says about it. Thank you.
Madam is from Salt City, sir.
Yeah, she's from Tuticorin.
Multiple tablets, poor adherence, increased costs, higher risk of drug interactions and adverse effects, and also inadequate weight management because of our traditional diabetic medications, hence failing to address the obesity component. So these limitations highlight the urgent need to bring about more comprehensive treatment strategies to address the multiple aspects of metabolic dysfunction. So as the years have gone by in the last 2 decades, our obesity management, we start with lifestyle changes, then behavioral therapy, which has found to cost only 3 to 5% of weight loss. So we have started them on pharmacotherapies, and without whom this full talk would not have come out. The best teachers are those who inspire us to be our best selves. Thank you, sir, for being a constant source of my inspiration. Thank you to all.
Thank you for finishing in time, and we have open forum now. Any questions?
Thank you, madam. Thank you for your extensive presentation. Just one practical question regarding the presently available anti-obesity drugs. After achieving weight loss, whether the patients are able to sustain the weight loss, or what will happen if we reduce the dose or stop the drug? What is going to happen?
Sir, what is going to happen is different. Patient, actually, it depends on the patient. He learns to eat less and he'll actually adopt to that lifestyle modification. If he adopts, actually, when we stop the drug, we see about a 10% of weight gain is there. But more than that, it's a habit, behavioral therapy, he has to follow it, sir.
Okay.
Thank you very much for the organizer as well as for all the delegates. It's an excellent program has been organized by Dr. Balamurugan and Dr. Rajendran. And these three topics are really wonderful, especially all the topics, and I think they need more time for the presentation or expressing their view. And I just have a doubt with my friend Vengo regarding the intergenerational. It's a wide spectrumic topic, very upcoming topic regarding the, he explained about the memory which is being transmitted from one generation to the offspring, even if the person is not exposed to that environment. That is the point of the core theme of the topic. And whether it can be, it is more of an epigenetic pathway. And any suggestion or maybe any data from the national health, I think it has been done extensively in UK. Any suggestion about the arrest the progress, or maybe any precautions or any medical therapeutical approach in breaking the barrier?
Exactly, sir. That is where the research is now targeted and focused. One simple thing is demethylation of the methylated DNA. Sooner or later we are going to be speaking on those molecules, but because they are not even in the phase 2 trials, we cannot speak on those, but definitely this is the future.
Yeah, thank you very much. It's a very extensive topic. And next one is the bariatric surgery regarding our therapy, especially in the weight reduction, has been extensively from the beginning till the end has been told very clearly about the role of bariatric surgery and the outcome, not only for the reduction of body mass as well as the metabolic outcome. And any new points which is being upgraded in the recent time regarding the bariatric surgery, any suggestion from anyone from the surgical side or gastroenterology beyond general medicine?
Joseph, sir.
Thank you, sir. Thank you for the opportunity, sir.
Thank you for the chairpersons from the thematic symposium. I finished earlier. Thank you so much. And next we are going to the keynote address, and I call upon the chairpersons Dr. G. Vijay Kumar and Dr. A. Pannisalam to the dais and take over the session. Yeah.
psychosocial support and mental health in diabetes care by Dr. Shanmugavel. Of course, Shanmugavel is known to all of us. He is very dynamic and academic person.
I have been already introduced to the learned audience,
Right.
so I don't
Over
need
to-
reintroduction. Okay. Respected chairperson, senior doctors, my doctor friends, and of course the organizing committee members. Uh, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on psychosocial support in mental health in diabetes care with a particular focus on evidence-based findings. I thank chairperson as well as the organizing committee members for their kind invitations. My disclosures, of course, I have no conflict of interest in relation to my presentations. So what I'm going to do for another 20 minutes, the contents of my talk plan includes introduction, prevalence, and clinical predictors for the psychosocial disorders, burden of a lifelong journey, psychological reactions, interrelationship between diabetes and emotional well-being, psychological therapies, strategies in the treatment of diabetes, and of course conclusions. So most diabetes care guidelines, they concentrate primarily on the medical aspects of initial management, often overlooking the critical psychological requirements of a patient. Many patients with diabetes, they effectively manage their conditions and maintain healthy lifestyles, and multiple studies including the Dawn study revealed that psychological support for this patient remains under resourced and inadequate. So it is quite challenging for the patient to accept the necessity of lifelong medications resulting in suboptimal care. So during each and every visit, we need to go into the details of the lifestyle modification, whether the patients are adherent to treatment, physical activity, adherence with reference to medications. So these psychological issues can eventually escalate into depressive or other psychological disorders, adversely impacting self-care practices. Recognizing the significance of psychological intervention in diabetes, various authoritative entities have integrated evidence-based guidelines for the psychosocial care in adults with diabetes. So prevalence and clinical predictors. So this meta-analysis encompassing 43 studies conducted in India indicated a pooled prevalence of depression approximately 38%, and rural residents and those from lower socioeconomic backgrounds, they demonstrated high rates of depression, and a systematic review published in 2021 highlighted what
risk of experiencing depression. Similarly, barriers in accessing healthcare services can prevent patients with type 2 from obtaining appropriate care for both physical as well as mental health requirements. So there is a complex interaction between biological, psychological, and social factors that contribute to the development and management of mental health disorders in patients with the type 2 diabetes. So the pathways of interaction between diabetes and mental disorders, and of course, we have the common risk factors, medication effects, next is unhealthy nutritional effects on the risk giving rise to mental disorders, in turn can result in worsening of the glycemic control. Diabetes patients per se, they may develop mental disorders. So mental health risk factors for type 2 diabetes, a biopsychosocial model. So mental health disorders. So we have the sociological factors, psychological factors, biological factors like obesity, next is diabetes, and next is we have the neuropathy, that is complications of diabetes giving rise to mental health or mental health disorders. So burden of lifelong journey. So managing chronic illness. So we need to focus our attention that diabetes is a lifelong journey. Hypertension is a lifelong journey. Dyslipidemia is a lifelong journey. Patient has to follow the lifestyle modification on treatment regularly and regular follow-up. So patient with the diabetes must oversee financial expenditures for medications. Next is routine healthcare consultation, potential complications, emergency department visits, hospitalizations, along with out-of-pocket medical expenses, which are the indirect costs attributed to diabetes, and financial burden of chronic disease. It can also account for the social determinants of health. Disparities in the socioeconomic status, they are the main contributor for associated complications. And patients with diabetes, they often experience fluctuations in blood glucose due to anxiety and as well as hormonal changes. And those with a higher fear of hypoglycemia may not administer sufficient insulin. They may skip the dose of insulin, or they may reduce the dose of insulin, greatly increasing the risk for diabetes-related complications. Stigma surrounding the diabetes is pervasive. That is diabetes stigma. It refers to the negative attitudes, judgment, discrimination, or prejudice that someone experiences because of their diabetes. Next is stigma surrounding, very important thing is patient with diabetes might conceal their self-management activities, such as insulin administration in public settings, mitigate feelings of shame, judgment, and discrimination. Next is weight stigma, often interacts with the diabetes stigma as negative attitudes and prejudices. So if a patient has both diabetes and obesity, they have both diabetes stigma as well as weight stigma. When pediatric patients with diabetes reach adulthood, support from family, friends, and treatment team during the transition is crucial to prevent fragmentation of care team and sustain self-management attitude. So very important, that is a stage where they may develop worsening of glycemic control. So relationship of psychological stress factors to the clinical presentations. So psychological stress induces metabolic changes. Response towards stress varies, especially in patients with diabetes. Type 1, variability can be attributed to autonomic neuropathy, and emotional distress in patients correlate with suboptimal glycemic control. Non-adherence to treatment regimens has been identified as a critical mediator between emotional distress and poor diabetes outcome, and reductions in depressive symptoms have been shown a positive association with a better glycemic control, and psychological factors including self-efficacy, self-esteem, diabetes coping mechanism, social support were found to be associated with enhanced treatment adherence and glycemic control. Next is ongoing environmental pressures. Diabetes-related distress, typically correlated with poor glycemic control. Psychological factors may contribute to metabolic or gastrointestinal complications as well as sexual dysfunctions. So psychological reactions. Psychological reactions, we have the emotional distress in diabetes with reference to emotional reactions, diabetic distress, and next is we have the phobic reactions that results in poor glycemic control, self-care behavior, as well as reduced quality of life and increased diabetes-related complications. So diabetes distress refers to unique, often hidden emotional burden. The symptoms include frustration, fatigue, anger. And of course, diabetes distress that is different from major depressive disorder. Major depressive disorder is a psychotic disorder that arises from emotional challenges. These are all the differences between diabetes distress and depression. Diabetes distress is an effective response to diabetes morbidity, and prevalence is greater and seems to be linearly related, not a significant risk factor for developing medical complications, and interventions may involve psychoeducation and supportive therapy. Depression, it's a complex response. Prevalence is relatively lesser, and it's a significant risk factor for developing medical combination. And interventions involve complex psychological interventions such as the cognitive behavioral therapy and of course the acceptance commitment therapy. Next is psychological reactions in patients. Depression was at least 10% higher among patients with diabetes. It contributes to underutilization of prescribed medications and leads to obesity, diabetes through lifestyle factors so associated with overweight, obesity, dyslipidemia, hypertension, and diabetes-related complications. Diabetes, on the other hand, can precipitate depressive symptoms due to major emotional, social, medical, and economic challenges. Psychiatrists prescribe antidepressant medications, particularly with the newer generation agents that induce weight gain, insulin resistant, thereby contributes to type 2 diabetes. And risk factors common to both depression and diabetes include abnormal fetal development, socio-economic disadvantages, unhealthy lifestyles, and of course chronic hypercortisolism, prolonged sympathetic nervous system activation, and hyperglycemia has also been implicated in neurodegenerative process in the brain. And of course, diabetes is characterized by chronic inflammation, predisposing depression, and through impact on synaptic as well as neuroendocrine function. And antidepressants may adversely affect glycemic control. These are all the comparison of socio-demographic profile of diabetic patient with or without depression, and comparison of clinical profile and quality of life, total and domain-wise scores of diabetes patients with or without depression. And next is again patients with role limitations, physical endurance, general health, how they develop depression, and so on. Next is anxiety. Patients with diabetes often navigate dietary restrictions, that intricate medication regimens, and presence of anxiety may adversely affect the dietary choices, physical activity, potentially leading to impaired glucose homeostasis. Coexistence of diabetes and anxiety may be associated with suboptimal glycemic control. Next is eating disorders. It's a persistent disturbance of eating or eating related disorders. And we have three main categories: anorexia, bulimia, and binge eating disorder. And diabetes is associated with increased susceptibility for all three eating disorders, with binge eating disorder showing high prevalence. And patients with diabetes deliberately script their insulin doses as well as oral OADs to reduce the body weight. And common risk factors for developing eating disorders include female gender, weight gain, body dissatisfaction, frequent cycles of dieting, as well as the history of depression. Next is other psychiatric disorders. We have the delirium. Next is outcomes such as disorientation, confusion, as well as altered sensorium. Next is close association between schizophrenia and diabetes, with approximately 20 to 30% of patients, they develop schizophrenia or pre-diabetes during psychiatric treatment. And emerging evidence suggests that insulin resistance may serve as a link between affective disorder as well as Alzheimer's disease. So fluctuating glucose levels due to this glycemia can lead to neuronal apoptosis and formation of neurofibrillary tangles, the hallmark of Alzheimer's disease. So next is interrelation between diabetes and emotional well-being. So stress, it's a condition of tension and agitation. Prolonged activation of stress mechanism can cause the detrimental effects on the body. Emotional strain is linked to unhealthy lifestyle pattern, and sustained physiological stress induces chronic activation of the hypothalamus pituitary adrenal axis as well as sympathetic nervous system. So this particular slide clearly shows the adverse changes with reference to lifestyle, hypercortisolism, overactivation of the sympathetic nervous system, as well as inflammatory pathways, and diabetes and mental or psychological dysphoria. So diabetes can cause mental dysphoria, in turn results in worsening of glycemic control or predisposes the individual to develop diabetes through chronic stress or genetic or social determinants. Next is health effects of emotions. Positive emotions are correlated with enhanced healthy behaviors. The physiological effects include activation of the autonomic nervous system as well as stimulation of the hypothalamus pituitary adrenal axis. And healthy behaviors triggers the excretion of endorphin, leading to a sense of elation. And negative emotions can intensify a range of health threats, stress, anxiety, and depression. And negative emotions can intensify range of health threats, contribute to prolonged infections, delayed wound healing, or as perpetuating elevated pro-inflammatory cytokines. So psychological therapies or strategies in the treatment of diabetes. So there is a pressing need for the development and implementation of effective, well-evaluated psychosocial intervention and therapies to assist patients dealing with the over-day challenges of diabetes, psychological screening and management at every level of diabetes care. It is crucial to sensitize healthcare professionals, patients with the diabetes, and their family members. So we need to have a family decision making. We need to provide proper education, motivation to the entire family members regarding the significance of psychological screening as well as intervention along with other recommended treatments. ADA position statement advocate screening during the initial visit at periodic intervals whenever there is a change in disease condition, treatment, or lifestyle circumstances. These best practices are often overlooked in clinical settings due to various reasons, mainly lack of time and resources. So the therapeutic approach on primary two modalities, psychosocial support, psychopharmacological agents. So we have guidance on self-care, cognitive behavioral therapy, social supportive networks, psychopharmacological agents, and recommendations for clinical practice. Conclusion. The relation between diabetes and psychosocial disorder is multifactorial. The emotional and psychological requirements are often undermined. Addressing the psychosocial needs of the patient would help improve health outcomes, better glycemic control. It is important to address mental health systems in a consistent and ongoing manner as part of diabetes treatment. So before I conclude my talk, let me invite all our delegates to register for this conference, 53rd Annual Conference of RSSDI, that is going to be conducted in Kochi from November 6 to 9. And please make yourself available and make this a memorable and a successful event. And of course, for the postgraduates, we request you to participate in this quiz competition. Thank you very much for your kind listening.
Thank you, sir. We'll have the discussion at the end of all the three.
One important announcement for the quiz participants, they should be here in this hall by 1:45. By 1:45. Thank you.
Next, you may invite a good friend, Dr. Anil Vidmani. Dr. Anil Vidmani will be speaking on trusted spaces as gateways to diabetes prevention. Something interesting. The topic itself is very interesting, gateways. So let us hear to Dr. Anil Vidmani and learn something.
Good morning to all of you, Honorable Chairperson and dear friends. At the outset, I would like to thank the Dr. Velu and the Dr. Vijay Kumar and the entire team of Trac for inviting me here today. My topic today is trusted spaces as gateways to diabetes prevention. No disclosures. Now, this is one of the largest epidemiological studies ever done in the world from Dr. V. Mohan's center, the ICMR INDAP study, and it showed that the prevalence of diabetes has almost stabilized at around 10 to 11% throughout the country. If you look at the IDF Atlas 2025, there are more than 89.8 million patients with diabetes, and India has the second largest number of adults. But what is more frightening is the prevalence of pre-diabetes, which is more than 15%. Now this brings us to the multi-million-dollar question. Is it time to focus on the prevention of type 2 diabetes? Friends, and there's a wonderful paper, a consensus statement from Ramchandran et al., call to action for clinicians in the Southeast Asian region on primary prevention of diabetes in people with pre-diabetes. Let me summarize this paper for you. It basically prioritizes prevention and cause this window of opportunity where we can prevent diabetes. Screening and early diagnosis to identify individuals at risk, personalized interventions based on the needs of each patient, national programs for prevention, management, and surveillance, addressing social and economic disparities, recommend strategies for integrating diabetes prevention into public health systems, empowering clinicians by providing practical guidelines which can be implemented in the primary prevention program both at the individual and community levels. Focus on Southeast Asia because this is the one where we are facing the tsunami. If you look at strategies for primary prevention, we all know mass awareness and education program all of us are doing. Screen and early diagnosis all of us are doing. But where we are stopping is identification of high-risk patients and risk stratification, which is very important. Now, lifestyle intervention is the most important part or the pillar of prevention of diabetes. And that is basically behavioral modification, which is the center stone of prevention. And they have non-pharmacologically, the mobile health or M-health has shown to facilitate these sustained behavioral changes with a wider reach, utilizing less manpower, time, and cost. And then, of course, we have the pharmacological, metformin is the only one that has been approved by the US FDA for the prevention of diabetes, but we have other two drugs, the pioglitazone and SGLT2 inhibitors, which have a very high potential, and we need more work and data on that. But remember, prevention is as crucial as treatment in combating the diabetes epidemic. Now, why prevention needs a new approach? We all know how to prevent diabetes, but we are not approaching it the right way. Despite all our efforts, diabetes continues to rise globally, and India is the top affected. Prevention efforts often miss the most at risk due to mistrust in the healthcare system. We must admit today that there is a lot of mistrust in the healthcare system. There are access barriers for the patients, it may be geographic, socioeconomic, language, or culture. And what are the strategies to overcome these barriers? Community-based outreach, that is the most important thing. This can help build trust, improve access to services. Culturally competent care by training the healthcare providers to be culturally sensitive and aware of the needs of diverse populations, and this can improve interactions and build trust. Addressing the stigma and working to reduce discriminatory attitudes can create a more inclusive and supportive environment for individuals who are seeking care. Expanding access to services by providing affordable, accessible healthcare services, including telemedicine, mobile clinics, and this can overcome geographic and financial barriers. Promoting health literacy, which is very, very important. It is an educated man or educated patient is the one who can be easily treated. In various formats and languages, going to the patient's own language to enable individuals to make informed decisions about their health. So the core thing that message I want to give you is building community-centric, inclusive, and impactful health engagements by using trusted spaces which offer a transformative opportunity. Now you may wonder, what are these trusted spaces? These trusted spaces are nothing but physical or social environments where individuals feel safe, respected, and heard. And these are the community centers, the faith-based institutions like the church, temple, gurdwaras, and so on, local pharmacies, schools, women's help groups. The key trait of all these things is that there is familiarity, there is cultural alignment, and non-judgmental atmosphere. And all these are very, very important. So why trusted spaces matter in the prevention of diabetes? As I earlier said, that behavioral modification is the most important thing if you want to prevent diabetes. The power of trust in health behavior cannot be underestimated. Patients who trust their doctors heal faster than those who do not trust their doctors. Trust builds engagement and adherence. Easier acceptance of screening, education, and lifestyle changes. Reduces fear, stigma, and resistance to medical interventions. We have been telling our patients to go for doing walking, yoga, and all that, but none of them used to listen to us. And Baba Ramdev came, and even the Prime Minister was doing yoga with him. So where was it? It was nothing but trust. There was mistrust in the healthcare system, and he was trusted. So people listened to him. Community-driven prevention models. There are real-world examples. The DCLIP study, where it was the lifestyle intervention was led by community workers. Faith and Diabetes program in the US, where churches are delivering the educational programs, and local self-help groups in rural India. Now let me talk about the DCLIP randomized control trial. Again, from South India, they are doing excellent work. And this is the Diabetes Community Lifestyle Improvement Program, randomized control trial in 578 overweight, obese Asian Indian patients with isolated fasting, isolated impaired glucose tolerance, and combined impaired fasting and impaired glucose tolerance in Chennai. And they were basically testing the lifestyle prevention measures. And what they did, they had community-based recruitment and randomized to standard lifestyle advice control for a 6 months period, culturally tailored US diabetes prevention program based lifestyle curriculum. And what did it emphasize? Weight loss, improved nutrition, and increased physical activity. And look at the dramatic results of this DCLIP study. There was a relative risk reduction of 32%, and the number needed to treat one case was only 9.8. Now, of course, there was a difference between who got the maximum benefit. Patients with impaired fasting and impaired glucose combined got 36% relative risk reduction, whereas patients with impaired fasting glucose got the least 12%. And it was stronger in patients 50 years and older and male or obese patients. And 72 patients required addition of metformin. So we must remember that isolated impaired fasting glucose may require some other intervention, and lifestyle intervention may not work in these patients. Then the other is the church-based program in the US. This was in New Dawn in North Carolina, a Diabetes Awareness and Wellness Network. And this was conducted among 24 churches. Participants were enrolled at each church, randomized as a unit to either special intervention or minimal intervention. There was individual counseling visits, 12 group sessions, 3 postcard messages from the participants' diabetes care provider, and 12 monthly telephone calls from a diabetes advisor or counselor. And this was nothing but a family model diabetes self-management education and support using church as a media. And this covered topics like healthy eating, physical activity, blood glucose monitoring, medication management, and problem solving. And they could prevent diabetes in a lot of patients. So what are the components of a trusted framework? Trusted spaces. We have to build a framework. Culturally competent educators, peer support systems, accessible and convenient locations, consistent presence, not episodic. It's not that you do a camp once a year and forget about it. Embedded digital tools like telemedicine, mobile health apps, and so on. So all this have to be used. What is the role of technology? Blending trust with innovation. Telehealth kiosks in temples or schools. There can be a small room-like thing where people can go and get advice or counseling. WhatsApp-based follow-ups by local health workers. Almost all of us are reading a WhatsApp daily. Artificial intelligence-powered risk scoring through community surveys. Digital nudges in native languages, sending patients messages in their own languages where they'll be easily access to it and be able to do it. And we need to have policy and program implications. There should be a partnership between the government and the non-governmental organizations, like we have the National Non-Communicable Disease control program. Training of ASHAs, accredited social health activists, and the auxiliary nurse, the ANMs in diabetes education, because they are a key component of the National Rural Health Mission in our country. And corporate social funding for community-based screening camps. These are very, very important if you want to manage it. And inclusion of Ayushman Bharat wellness centers. Now there are challenges and safeguards, and it is very important to address privacy concerns in tight-knit communities where they don't want outsiders to come in and interfere with their daily work. Avoiding misinformation from informal channels. We should give them. It should not be from the WhatsApp university. Ensuring evidence-based practices and sustaining trust without overburdening the community actors. So it is a missed but a powerful frontier. Remember, prevention is personal. Trust is the currency. Build partnerships, not just programs. Let's bring care where people really feel cared for. It's very important. Now, no talk on prevention can end without talking about so-called primordial prevention or the efforts in early life, which have been promoted by Professor B. Sheshaya. And this is the peri-conceptual period covering the first 1,000 days of life. The main aim is to improve the maternal health, the fetal health, and basically focus on the fetus for the future. And that was even the message of the WHO this year: healthy beginnings and hopeful futures. Otherwise, what we'll have? We'll have babies like this. Childhood obesity is one of the biggest problems, and it is rising at an alarming rate. Studies done in Delhi schools and Maharashtra schools have shown an alarming almost 20 to 25% of prevalence of obesity in childhood. So we need to take care of that. And this is a wonderful Hindi share by Gulzar, which says, "Khali pada hai mere pados ka maidan, ek mobile bachon ki gend chura ke le gaya." Which means because of the mobile, the children are so interested in the mobile, they are not playing in the fields any longer. They are not getting any exercise. So this is a wonderful thing which tells us the sad state of affairs today. Friends, the battle against obesity and diabetes cannot be won in the boardrooms of the pharma companies. Getting drugs, 15% loss, 20% loss is all bullshit. But it will be won in our kitchens, dining rooms, schools, workplaces, along with public policy and trusted places. So this is where we need to put our attention. Thank you for a patient hearing.
Excellent, excellent. Virmani sir, I think you didn't talk about how to prevent, but you have given a different perspective. It says, what is it we need to do, where is it we need to go? That's a very, very interesting, it's a good message for everybody who is in the hall. And then I think you should go for the trusted spaces. I would like to give one example what we have done about 20 years ago. We went to the campus in IIT, that is Indian Institute of Technology in Chennai. We went to that. And then we detected about so many people having dysglycemia. We just educated them. Next year we went and again rechecked. Believe me, 68% reduction in dysglycemia was
Right, absolutely right.
So I think this community based, I think that can spread overflow to the other places as well.
We have
That's
been
one
focusing
thing.
on the wrong areas.
I think the message is that it should not be what to do, where to do.
Right, sir.
I think that's
Right.
an excellent thing. I
Absolutely.
think it's a different perspective. I think trusted spaces. Excellent, sir. Thank you.
Thank
and
you,
you
sir.
also mentioned about the metformin and SGLT inhibitors and pioglitazone as well. Metformin, though DPP2 study differently told, Dr. Ramchandran study said that lifestyle modification and metformin are equal in converting the pre-diabetes to diabetes.
In fact, I have found pioglitazone is the best drug in prevention.
And then if you look into the Defranzo and Sundar Mudaliar study, where they use pioglitazone, 85% conversion rate has been reduced. That's one. Unfortunately, SGLT inhibitors, as of now, we don't have any prevention. But what we are seeing is that those people who had, reactive hypoglycemia, when you're putting them, they're losing weight, reduction in insulin doses, and abdominal fat coming down, and they're doing better. So I think, thank you, sir. It's a very excellent tool.
So the message, you have taken the different view on prevention. Of course, we all know here that we all know about prevention. Of course, my message is, for example, to reduce polio drops, we are not in a position to collect all the less than 5-year-old children 20-30 years before. Now they have reached all the children. Similarly, the government should take initiatives. We all keep on talking IDF to this level. But as we all know, the disease is growing like anything. But towards prevention, towards early detection, unless the government takes efforts, because through government we have achieved so many things, waterborne diseases, plague, or HIV. Without vaccine, with the help of vaccine, we have tackled only 2 diseases, smallpox and polio. Remaining other diseases, plague, or guinea worm, cholera, all those diseases without vaccine we have tackled. Similarly, for diabetes, as we know, we keep on talking for more than 30-35 years, allowing the disease to grow all over India, all over world.
Nice. Thank you.
Come on. Hello. Do dogs take sweets? Anybody have dogs in the house? Do dogs take sweets? Dogs. Pet animals, dogs, do they take sweets?
Our, my dog takes sweets.
Okay. Normally we don't give salt or sweet to the pet dogs. We don't give the dogs. So I have 3 dogs. The dogs never taste the sweets because we don't train them to taste the sweets. The message is that
salt is more
dangerous. Why don't you train our children not to give sweets at the age of 5? Why do you train the taste buds to sweets? Now the contest is coming. Don't give salt till the age of 2 years. Till the age of 2 years. Don't train the children's taste buds to sweets and salts at a very young age. So they get trained to all sorts of junk foods. Today I have seen Jigir Danda. He supplied here in a diabetic conference.
Sir, what you said is very pertinent, sir, because
you,
there is one thing called as
very prudent. I tell you, we give our children right from the day of the 2nd month, 3rd month, so much of sugar, so much of milk added with sugar. I think that should be the way.
I think very pertinent point, because there is one concept called childhood memory.
Yeah.
See, the way more you eat during childhood, you eat more even adulthood. Actually, that's what it is.
Because till the age of 1, the child with the mother's milk, after age of 1, the child trains his taste buds to different acts of food. Why do you expose them to harmful foods? Don't give sweets to children. Please don't give sweets to children till the age of 5. We can definitely have a better prevention of diabetes more than all what we have earned enough. Because you have heterogenic, your appetite, your center in the brain gets trained to that. Yes, you get trained to that. I think, thank you, Vijay, for the...
Thank you, sir. Thank you. We'll move on to next
One
session.
minute, Dr. Paneer. Supplying Jigardanda, that is just to test the doctors who are with diabetes whether they are taking or not.
No. You can take once in a way Jigardanda, not every day,
No,
not 3 times
that is
a day.
doctors-
That's okay.
doctors
Once in a
who
way
are
taking is
attending.
nothing. Anything in moderation is okay.
Right, sir. We'll move on to 3rd topic, HbA1c and heart disease by Professor Dr. R.S. Hariharan. R.S. Hariharan sir is known to all of us, teacher of mine and teacher of many of us, teacher of teachers. Over to Professor Hariharan sir.
Good morning, ladies and gentlemen. At the outset, I would like to thank the organizing committee and Dr. Shanmugavelu and others for giving me this opportunity to talk to you this morning. Respected chairpersons, thank you for the kind introduction. I will be speaking to you on hemoglobin A1C and heart disease. Now, is it the same as diabetes and heart disease? What am I trying to address when I talk about hemoglobin A1C and heart disease rather than diabetes and heart disease? You can only compare it to, is diabetes a heart disease or a diabetic disease? Now, do you know that before the 1990s, hyperglycemia was not believed to contribute to cardiovascular disease and type 2 diabetes? In fact, if you look at the classification of heart diseases in the textbook of those days, you would find something like congenital heart disease, rheumatic heart disease, atherosclerotic heart disease, hypertensive heart disease, syphilitic heart disease, and so on. But is there a diabetic heart disease? This was never mentioned in those books. It was not in existence at that time. Now, this is Miles Fisher, who said diabetes should be defined as, now let us look at the definition that we used to have as far as diabetes is concerned from Professor Sam G.P. Moses' days. You say diabetes is a metabolic cum vascular disease due to relative or observed insulin deficiency characterized by glycosuria and or hyperglycemia and associated with complications such as microvascular complications, retinopathy and nephropathy, and macrovascular complications. So an elaborate definition. But look at this gentleman who says diabetes probably should be redefined as a state of premature cardiovascular death which is associated with chronic hyperglycemia and may also be associated with blindness and renal failure. So he literally relegates retinopathy and nephropathy to the background, highlighting the fact that diabetics often die a cardiac death, whatever be the underlying complication. Even renal failure, patients quite often die of a heart failure or a heart myocardial infarction rather than renal failure. Now that's what exactly is the crux of the problem. Now, if you look at this slide, it elaborates the involvement of the various structures of the heart due to diabetes. You know that diabetes is a metabolic cum vascular disease. And the vascular one is microvascular and macrovascular. The metabolic complications as far as the heart is concerned is the result of metabolic arrhythmias, either due to FFA when there is uncontrolled hyperglycemia, or of course hypoglycemia in the other extreme. As for the vascular complications, the macrovascular is the time-honored macroangiopathy, coronary heart disease, and microvascular angina is angina despite normal coronaries. Diabetic cardiomyopathy is also a microvascular complication of diabetes, and cardiac autonomic neuropathy because of microvascular neuropathy of the heart, which is reflected by your cardiovascular reflexity, is yet another complication. So diabetes affects each and every part of the heart. Now, if you look at the history of hemoglobin A1C, it was virtually an accidental discovery in 1968 by Samuel Rabar, who discovered that hemoglobin A1C is elevated in diabetes. He was just looking at the hemoglobin A1C, all patients. He said all diabetics seem to have a higher hemoglobin A1C. That is why hemoglobin A1C was discovered at that time. It was Anthony Cirami in 1976 who proposed that hemoglobin A1C be used for monitoring glycemic control in diabetics. Subsequently, in 2010, ADA recommended the use of hemoglobin A1C to diagnose diabetes, pre-diabetes, as well as stress hyperglycemia. So Cirami introduced it for monitoring control. ADA recommended for diagnosis of diabetes, pre-diabetes, and stress hyperglycemia. Now we do have today a third dimension to hemoglobin A1C, that is hemoglobin A1C and heart disease. Cardiovascular diseases, as you know, rank as the #1 cause of mortality in the world. 31% of all global deaths are due to cardiovascular diseases. More than 70% of patients with type 2 diabetes die of cardiovascular causes. It is therefore imperative to identify and control the various risk factors if we were to prevent cardiovascular diseases. So looking at the CV risk factors, we are all familiar with the traditional risk factors which are either modifiable or non-modifiable. Modifiable meaning blood pressure, lipids, diabetes, BMI, smoking, etc. Non-modifiable is of course the age and gender. Today we talk about novel risk factors, out of which HSCRP is well established now. We are now talking in terms of whether hemoglobin A1C is also a marker for cardiovascular risk. Now, glycemic control and complications of diabetes. This ADA-AHA-ACC recommendation says, as far as microvascular complications are concerned, glycemic control is a class 1 recommendation. There is abundant epidemiological RCTs that confirm the benefit of glycemic control as far as the microvascular complications are concerned. But when it comes to macrovascular diseases, it's only a class 2B recommendation. Effect benefit with level evidence A, less well established by evidence or opinion. So that's as regards the macrovascular complications of diabetes is concerned. Now let's look at the study, an association of glycosylated hemoglobin with cardiovascular outcomes in the general population, results from so-called biomarker study to identify a novel biomarker in hemoglobin A1C to improve the cardiovascular risk assessment in general population without diabetes as well as with diabetes. The observations were hemoglobin A1C was independently associated with overall mortality, CV mortality, and CV disease. This association was monotonic and not J-shaped and increased all three outcomes in diabetics and non-diabetics. As you can see here, whether it is cardiovascular mortality, cardiovascular disease, or overall morbidity, the association between hemoglobin A1C and hazard ratio of CV events was progressive. As the hemoglobin A1C increased, the risk of all these three complications increased. As a risk stratification, a hemoglobin A1C more than 5.7% was particularly important. An association between hemoglobin A1C and cardiovascular death was strongest in individuals aged less than 55 years. The limitations are of course obvious. The presence of hemoglobinopathies, different ethnicities sometimes, and certain disease tests like bleeding, transfusion, or hemodialysis can interfere with the measurement of hemoglobin A1C. Other is in those less than 55 years of age, a hemoglobin A1C more than 5.7% is considered a high risk for development of cardiovascular disease. Now this is yet another study which had a meta-analysis of 46 studies, found an increase in the risk of all-cause mortality in diabetics as well as non-diabetics. The cutoff point for increase in mortality in diabetics was more than 8% and in non-diabetics more than 6%. Likewise, diabetic with less than 6% and non-diabetic less than 5% hemoglobin A1C also had higher all-cause mortality. So the inference from this group of studies is that hemoglobin A1C is a reliable risk factor for all-cause and CV mortality in both diabetics and non-diabetics. Optimal hemoglobin A1C levels for the lowest all-cause and cardiovascular mortality ranges from 6 to 8% in diabetics and 5 to 6% in non-diabetics. The study also emphasizes the clinical importance of preventing hypoglycemia in diabetics. Hemoglobin A1C may therefore be included in the algorithms to calculate CV risk factor in the clinical setting. This is yet another study which estimated the glycosylated hemoglobin in relationship to cardiovascular outcomes and death in patients with type 2 diabetes. It found that each 1% increase in hemoglobin A1C was associated with 17% increase in the incidence of cardiovascular events. As far as those without known diabetes, hemoglobin A1C levels above 6% was associated with a 20% risk of CV events. So physicians should consider including hemoglobin A1C as yet another biomarker for the risk assessment of cardiovascular risk in diabetics as well as non-diabetics. Now this is a study where hemoglobin A1C levels and the risk of cardiovascular disease in people without known diabetes was carried out, and you will find the hazard ratio for CV events according to continuous hemoglobin A1C levels without known diabetes also showed a similar trend. The findings were both high and low levels of hemoglobin A1c were associated with an increased risk of cardiovascular deaths among participants without non-diabetes. Association between hemoglobin A1c and CVD risk was non-linear. Low levels of hemoglobin A1c were associated with increased risk of stroke, especially hemorrhagic stroke, while diabetes and high hemoglobin A1c levels are associated with increased risk of coronary heart disease and stroke, especially ischemic stroke. Low hemoglobin A1c levels are also associated with increased risk of all-cause mortality in people without diabetes. So data support the notion that a very low and very high levels of hemoglobin A1c may be markers for identifying people with increased health risk. Now, looking at the difference between men and women, this study shows that among men, hemoglobin A1c at all levels, whether it is normal, pre-diabetics or diabetes, was associated with an increased risk of cardiovascular diseases. Whereas in women, CVD risk was restricted to those with hemoglobin A1c level equal to or more than 6%, that is only in pre-diabetes and diabetes and not those with normal glucose tolerance. That is, one should optimize the CVD risk factor management at all levels of glycemia in men more than women. So to summarize, hemoglobin A1c is being used to diagnose and monitor diabetes and other categories of glucose intolerance hitherto. It is now emerging as a new and novel risk factor for heart disease and other cardiovascular diseases, conferring a new third dimension to it. This association is seen in diabetics and non-diabetics. The cutoff point in diabetics is more than 8%, while that in non-diabetics is more than 6%. Some studies have shown a J-shaped relationship in that a hemoglobin A1c less than 6% in diabetics and less than 5% in non-diabetics is associated with higher CV and all-cause mortality. This emphasizes the importance of preventing hypoglycemia in diabetics. Optimum level of hemoglobin A1c for preventing cardiovascular and all-cause mortality is 6 to 8% in diabetics and 5 to 6% in non-diabetics. Each 1% increase in hemoglobin A1c increases the incidence of cardiovascular events by 17 to 20%. There is a gender difference in this association. Hemoglobin A1c should be included in the risk assessment algorithms for cardiovascular diseases as yet another novel biomarker. The carry-home message is very simple. Today, hemoglobin A1c is emerging as a novel biomarker to improve cardiovascular risk assessment in general population on par with serum cholesterol, blood pressure, etc. Thank you very much. Thank you for a patient hearing.
Sir. Sir, one small clarification, sir. Sir, in diabetic, 6 to 8 is the cutoff you have told, sir. But even 7, 7.5, 8 also has more of cardiovascular risk in HbA1c, sir. But you are giving the upper limit up to 8%.
Yeah, that's what exactly long term, especially below 55 years of age. Below 55 years of age.
But there are a lot of papers.
You should try to keep it less than 8, less than 7, preferably. Up to 8 is still okay.
Less than 7, all right, sir, but cutoff was 8, sir.
This is a long-term study on enough thousands, not thousands, 10,000s of patients.
Right, sir.
Now this is for macrovascular disease. You must understand that. Because we know for microvascular.
I think you take with a pinch of salt as a marker of A1c to judge the cardiovascular outcome. I think it's a more of combined risk factors of not only diabetes, also the smoking, dyslipidemia, obesity, sedentary lifestyles.
These all based on after other things have been excluded. How will you now react to your HSCRP?
Quite possibly, I tell you the studies, ACCORD studies, all those who try to control the A1c to a very tighter control in the elderly population, they fail. Probably the message may be that the A1c, if you try to keep it less than 6 in elderly population, may have a hazardous effect. But I don't know whether we take A1c alone as a marker for cardiovascular.
No, he said in addition, no, no.
A1C is one among them,
We
but
say it is
A1C
one
can
other
be
marker.
eight.
We didn't say this is the only marker.
One among the markers.
Now, this topic itself is new. In fact, that is precisely why I wanted to talk about this. This particular concept is new. You won't find it ordinarily. Now, with this idea, you go and refer and read, you will know that this is emanating as a newer marker, one other concept.
Yes,
Now, you know for sure, there is a linear relationship between cholesterol and cardiovascular death. Hypertension or blood pressure on cardiovascular, but we never thought that this is also a marker continuously for cardiovascular death, because that's what I said. Before 1970s, we did not even know that diabetes is associated with heart disease.
Yes,
Now that we know, this is also coming as one other thing where you have to look up. So when you write down age, sex, smoking, cholesterol, BP, now you add hemoglobin A1C and not diabetes. That's what exactly it means.
But sir, we all understand that, sir, but A1C at 8, that's what we are asking.
Preferably less than 55.
Less
You know,
than
most
7.
of your patients are stuck at that time.
Sir.
Yeah, there's one other thing. That's what I'm saying.
So one thing, no, that what we have seen in UKPDS, over 15 years of follow-up in UKPDS, any reduction in HbA1c has been associated with reduction in cardiovascular disease. Like, in the 15 years, what has happened was that both the control arm and as well as intensive arm, both have upper limits of more than 8 HbA1c.
Not macrovascular,
No.
Vijay
No, for macrovascular disease, sir.
Not macrovascular.
That is macrovascular disease I am talking. Just 0.9% reduction, the difference of HbA1c is associated with 18% reduction in cardiovascular disease. Any HbA1c reduction is very useful. That's one thing. Sir, one more thing, sir, the new concept we have discussed one of our journal clubs, like glycemic variability, there is one thing called as HbA1c variability. So we need to keep the HbA1c constant, as Professor Hariharan is telling, it should be constant. One time it is 7, one time it is 9, one time it is 6.5, it doesn't help at all. It's a constantly reduced HbA1c is the most important thing. They call it HbA1c variability, which is a new concept.
Sometimes you can have a normal A1C, but if you look at the ABG profile,
Known, sir. That is known, sir.
That is
yeah,
known.
that's what the glycemic variability may be a better marker than A1C.
Yeah, that is known. That is
No,
why
but
it's
what
one
I'm
of the
talking is
others,
HbA1c variability. That also is very important.
Because of glycemic variability, HbA1c variability. Right, sir. Thank you, sir.
Thank you, sir.
Thank you.
As usual, wonderful talk.
All I want to emphasize this is a new area. This is a new thing that is coming up. Whenever something is new, nobody is going to agree. Over time, everybody will come around. Thank you.
Thank you, sir.
So thank you, chairpersons, for this wonderful session. And before the next session, I am having an important information.
Just one small announcement. Good morning to all. The next year, Trac2026 will be held in Madurai on behalf of the organizing committee under the leadership of Professor Dr. Asirvadam. I like to invite you personally for the function or for the CME. You can have a very good academic feast as well as
in the keynote address, an important session for Professor Sam G.P. Moses oration. I call upon the chairpersons, Dr. Anand Moses, Dr. A. Muruganandan, and Dr. Isaac Christian Moses. Anand Moses. So Anand Moses and Dr. Shanmugavelu are going to chair the session. Yeah, and Shanmugam also. call upon Dr. Sanjay Agarwal.
The Tamil Nadu RSSDA welcome our Secretary General of RSSDA, Dr. Sanjay Agarwal. Thank you for sir coming here for your efforts. Thank you. Welcome you sir from because of RSSDA Tamil Nadu. So I request our scientific chairman Dr. Shanmugam sir to read the citation for Professor Sam G.P. Moses oration.
Respected our guest speaker, Professor Dr. Sanjay Agarwal, chairpersons, senior doctors, my doctor friends, it gives an immense pleasure, happiness and honor to read out the Professor Dr. Sam G.P. Moses oration. RSSDA Tamil Nadu chapter with great pride honors Dr. Sanjay Agarwal, an internationally respected clinician, academician and visionary leader in the field of diabetology, with the Professor Sam G.P. Moses oration at Tamil Nadu chapter RSSDA Annual Conference 2025. Dr. Agarwal, MD, FAC, FACP, currently serves as Secretary General of the Research Society for the Study of Diabetes in India and holds dual institutional leadership roles as Director, Department of Diabetes, Obesity and Metabolic Diseases, Ruby Hall Clinic, Pune, and Head Department of Diabetes and Obesity, Satyadri Hospitals, Pune. His influence extends to the global stage as a member of both the steering committee and the governance committee of the International Diabetes Federation, shaping global diabetes policy and advocacy. With a career spanning over 3 decades, Dr. Agarwal has been at the forefront of clinical care, research, and medical education. He has played a pivotal role in formulating national diabetes guidelines through various RSSDA writing committees. His editorial contributions include membership on the BMG Open Diabetes Research and Care Editorial Board and serving as Associated Editor of the International Journal of Diabetes in Developing Countries. He has edited the authoritative RSSDA insulin monograph and co-authored the acclaimed Clinical Atlas of Diabetes mellitus alongside the late Dr. Attilio Rolla of Harvard Medical School. A prolific academician, Dr. Agarwal has published over 25 peer-reviewed research papers and served as principal investigator in multiple landmark international clinical trials that have influenced diabetes management globally. His passion for capacity building is evident in the training of thousands of physicians via CME programs, fellowships and academic collaborations with world-leading institutions such as the Joslin Diabetes Center and Emory Diabetes Training Academy. Widely admired for his patient-centered approach, his vision for a digitally enabled diabetes ecosystem, and his unwavering commitment to improving outcomes for people with diabetes, Dr. Agarwal's contributions encompass clinical excellence, research innovation, education, policy, advocacy, and organizational leadership. In recognition of his lifetime service, scientific contributions, and transformative leaderships in diabetes care, the Tamil Nadu chapter of RSSDA is privileged to confer upon Dr. Sanjay Agarwal the Professor Dr. Sam G.P. Moses oration at Tamil Nadu chapter RSSDA Annual Conference 2025 with heartfelt gratitude, deep respect, and enduring appreciation. Thank you very much.
Good morning, everybody. And I'm extremely humbled with this honor that has been given to me by the Tamil Nadu chapter RSSGI. It is indeed an honor to give Professor G.P. Moses oration, a dream that has come true after long years of work in the RSSGI. So I would like to thank the entire leadership of Tamil Nadu RSSGI and the members for conferring me this oration. I think every person has a defining moment, and you have to craft out your own defining moment. For me, the defining moment was becoming the secretary of the RSSDI. And I say this as a defining moment for me because it gave me an opportunity to do what I wanted to do for people with diabetes. And I thought that this may be the best way that I could be part of the decision making, which will probably, make a lot of changes in the ecosystem of diabetes care. And RSSDI being the leading organization in India, I thought that this would be the best platform by which we could enforce a lot of changes that may help people with diabetes. I'm extremely thankful to all the members of RSSDI, to all the state executive committees, my central executive committee, all the past presidents, the patrons, and the presidents along the way who have laid the foundation of RSSDI. There isn't an organization in India which does not have such a strong legacy of hard work and the forward thinking that our founder fathers had. I think the Tamil Nadu has contributed tremendously to the growth of RSSDI. And we take deep pride in saying that because right from the inception onwards, till date, Tamil Nadu has been in the front contributing to every activity of RSSDI. So past, present, and I see a lot of future leadership out here sitting in this audience who's going to take Tamil Nadu much ahead in the entire ecosystem of RSSDI that is countrywide. So I congratulate every member sitting over here for their contribution to RSSDI, right from research to policy making to participating in various initiatives of RSSDI. I think Tamil Nadu has always been in the front. So thank you very much for being part of us. The RSSDI was started in 1972, and Professor M.M.S. Sahuja, whom you can see there, Professor Sam Moses, and many others who Professor Vishwanathan, who are the founders of RSSDI, gave it a vision. And I was very privileged to work with Anand over here in my first inception into the Central Executive Committee, the first 3 years, when Anand and I were both in the Executive Committee. And I would like to put it on record to say that I was just a novice. I'd done a term in State Executive Committee, but Anand guided me through the nuances of what RSSDI is, because he's been a guiding force for RSSDI for so many long years, as well as for Tamil Nadu. So thank you very much, Anand, for being part of me in the formative years that I was in the RSSDI. When I look back and I want to really define what I wanted to do, I would probably break it down to what I wanted to set my agenda as core values for RSSDI, defining goals, building leadership, creating value chain for members, creating meaningful collaborations, and the roadmap for future. I think this has been part of my journey over the last 6 years as a Secretary General. The core values actually came from the founder fathers, and if you look at the initial document which was shared to me by Dr. Vinod Kumar, who was the first Secretary General of RSSDI, he and many others who started the organization put the aims and objectives of the founders as to encourage and support clinical and laboratory research in the field of diabetes, to hold workshops and scientific meetings within the country to gather scientists involved in the field for discussions or demonstration of laboratory procedures and seminars, to encourage collaborative studies at national level and help training workers in various research techniques in the world. So this was the vision of our founder fathers. But in the last 53 years, we have realized the challenges of diabetes in the country. We have seen the leaps and bounds by which we have increased the number of patients with diabetes as well as the complications related to diabetes, not only type 2 but even type 1. And somehow we have now sort of come around to say that we have grown beyond these aims and objectives to see that how can we improve lives of people, bring down the trends of increase of diabetes population, and perhaps make, reduce the complication burden that people tend to have. So we have now emphasized a lot on clinical care, on awareness, on advocacy, trying to work with governments, state and central governments, because unless we have our own sort of way by which we can influence governments, we will not be able to reach the deeper sections of the society where change is perhaps necessary. I built the goals on 4 pillars: encouraging research, patient engagement, education and encouraging publications, and most important is organizational strengthening. Because as the organization grows, we need to put a roadmap for the future to see that the organization runs on a tight course and nobody can change the course. It can only go up, up and up, and that will be the best way forward. With all the coming leadership, there is a sort of a roadmap that they can follow. This was the vision that I started with, a united, future-ready RSSDI, which is going to be inclusive, innovative, and impactful. And the mission was, of course, to empower every member, foster meaningful collaborations, and lead with clarity and purpose. And to a certain extent, I hope I've achieved this in the last 6 years. So I would like to lead with a purpose to impact changes. I must put on record all these presidents who have been part of my journey. The first 3, of course, as an executive committee member when I was inducted into the Central Executive Committee. And the last 5 were the presidents that I have worked with as a secretary. And believe me, all of them have been incredible. They've all been different personalities, but working with each one of them have been enjoyable and a learning experience for me. 2 people who would probably stand out for my contribution is Dr. Sarita Bajaj. I would say that because she was the one who said to me when I got inducted that you're in a position which many wanted to be in. Use this moment to see that you can make the change possible. And that was something that I never forgot ever. And Dr. Bansi Sabu, who was the one who actually I started my journey with as a secretary, and his inclusiveness, his energy, his dynamism, and the way he led the organization in difficult times, because that's the time when both of us started our journey was in COVID times. And we all know the difficult times that COVID were. But we made every problem an opportunity for us to see that we could lead the organization from the front, even in those difficult moments. And then Vijay, my current president, has always been so supportive of whatever I do that I can only thank him that as I conclude my journey as a secretary this year, he's been the person who's been with me in my last year of my leadership as a secretary. So I think all these presidents have been a part of me and have always told me what to do and probably guided me whenever I've been in troubled times. I want to break down today my entire presentation into 3 sections. One is how has RSSDI gone through a period of transformation. Then we have gone through a phase of consolidation. And now, of course, as we come into the 53rd year, we are setting trends for the future and see that in the coming years, we are on parallel with any world organization and perhaps even better than. So let me start with the period of transformation. As I said that I started my journey as a secretary during the COVID times in 2019. And during that time, I think all of us are familiar that we didn't know exactly what was happening. We didn't know how to treat our patients. How could diabetes impact the outcomes of our patients with COVID? We saw all the mortality, all the confusion. But even on those times, we as a group, the entire RSSDI, all the executive committees sat down and at individual places in every part of the country, we could bring out guidances as to how we should sort of manage our patients with all these advisories that we came out with. And I must say that Tamil Nadu was actually the one who gave us the directions in making this advisory, and some of these advisories have been done by the Tamil Nadu RSSDI chapter. So thank you very much for giving us this contribution. the face of the organization is always the website. And we revamped, and I was instrumental in starting the new website. Today, if you see the website, it has every single activity what the RSSDI does, not only in terms of just showing what we do, but it has opportunities for people to collaborate, learn, educate, research, and everything today is available on the website. And I urge each one of you to go to the website. We have also made a web app of this so that you don't even need to use your computers, but on your own phones you can download the RSSD app and you should be able to look at the entire website on your own phone. These were the enhancements that we did, and I'm sure you'll know. But one of the things that we did was, in collaboration with Breakthrough T1D, the former GDRF, we created a type 1 diabetes platform. We do know that today in India we have the largest type 1 population in the world, and we wanted to see that we can handhold all our type 1 population. And this has been a huge resource for patients with type 1 diabetes that you can look at, and hope that you can give this to your type 1 patients and they'll find value and how they should look at all the resources to help them manage their to manage themselves. We believe in democracy, and earlier we used to have the ballots, but we said that every member of RSSDI is important to us. Every member should have the opportunity to be a leader. And because we want to see and encourage everyone in the periphery, including the villages, talukas, districts, who will feel that they have the capability to lead the organization, to come in and contribute. And towards that, we started a democratic process of e-voting, and successfully for the last 5 years, we have done a lot of state as well as central elections through the e-voting platform, which has been a learning process. We have evolved, but today it's a very mature platform, and you can see today the current, the central elections are going on, and some of our members are part of the, who are standing. I have Vijay over here, I have Shanmuga Velu over there. I don't know if I can see the others who are part of the process, but I wish all of them success. I said Vijay, yes. So I wish them lots of success in the elections. We framed the Constitution in 1972, and at that point of time, the Constitution had all the elements which were relevant at that point of time. But 2 years back, and that was in Chennai, the Chennai meeting, we framed the new Constitution of RSSDI, and we have now put the Constitution looking at the roadmap for the next 10 years to see how we should make the changes possible. And this was adopted widely by the AGM during the Chennai meeting. So today we have a constitution where we have done away with some of the elements that were not relevant, but we have included elements which will lead the organization for at least the next 10 years. All our grants today, we are very open, transparent, and we want to support research. So we have broken that down, that every quarter we will have submission of the grants. We outline a lot of money to see that we can support research, and you can submit your grants online. There is a review process, a fair review process that happens. And going forward, the executive committee along with me took the decision that since we are not a very, we don't have unlimited funds, but we should focus on supporting research that will change lives of patients. So we said that maybe we should have 8 or 10 sort of questions that should be answered, which will make changes possible for patients with diabetes and support research. So this has been a forward thinking that we are trying to do, and we are trying to support research as much as possible. As our ethos of RSSD has always been research, and the name RSSD includes the research, we had earlier a single meeting which was more clinical in nature for all the practicing physicians, and we thought that we should have a separate meeting, the research retreat, which we started doing it in the first half of every year. So we started with Pune, and the last meeting was Dr. Velu who did this in Madurai, and it was one of the most successful meetings that we have had of the research retreat, where not only we had healthcare professionals who participated in the meeting, but we had entries from various biotechnology institutes, science institutes, IITs, ICERs, ISECs, who also work in the ecosystem of diabetes, but they never get the access to us because they work in their own space, we work in our space. We want to see now we create a cross bridges, and we have people from different walks of life who do anything with diabetes and its research should be part of this meeting. And I think Dr. Shanmugavellu, Dr. Balaji, the entire team that was there did an incredible job to see that the meeting was a big success, and we had great science that came out of it. When I started, the membership was about 6,000, and today we are very proud to say we have 13,000 members, which has been the landmark, because today in the world we have the largest healthcare professionals who are involved in diabetes care as an organization. So we are the largest organization in the world with healthcare professionals who are involved in diabetes care. I'll come to the next phase of my talk, and that is the phase of consolidation, because this was the initial formative changes that we needed to do to see that we take RSSDI much ahead. Reaching the masses was very, very important, because as an organization we cannot be limited to only the metro cities or the urban areas. For us, diabetes care lies in the rural belts and the tier 3 and tier 4 cities. That's where the resources are limited, the expertise is limited, and as an organization it is our duty to see that we reach out to all the masses who are right there, who need us most. And we had a number of things that we did as a consolidation processes. We did the district coordinator network, and every district today is represented by a coordinator which has been trained by RSSDI, and every state has contributed district coordinators, and we're trying to enhance this further all the way up to the talukas also. We've got the village adoption program, and with the village adoption program we are trying to see that can we put down minimum care standards in every village, and we've had Tamil Nadu contribute a lot of villages which they have adopted, as well as UP, Maharashtra, Rajasthan, so many states who have been contributing to the village network so that we can bring some minimum care in the different villages of the country. And today social media has become a very important platform, because people look at social media platforms, and I thought that RSSDI should be on the network so that the world follows us. I've not put the slides, but we've had all the world's leading organizations who are following us as to what RSSDI does, and this is just an older slide on the followings that RSSDI has. We've reached out to patients through our diabetes bites, and during troubled times we've also used the media like NDTV and others who have, where we've given interviews. Number of programs to reach out to the masses has been through the TV medias, and I think as a knowledge partner, a lot of TV medias reach out to us. We partnered with Sanofi in our type 1 care with a very large grant. We could support about 1,500 children to give them free insulins through 37 centers all across the country. Because we know that the number one reason why type 1 children die is because of lack of availability of insulin. And that's been a concern for us. We have been reaching out to a number of NGOs and charitable organizations to see how can we adopt more and more type 1 children to bring type 1 care, more better care, as well as provide insulin for all of them. We participated in the Kumbh Mela, and this was part of the awareness program, and I can tell you we published a paper and we got some great results that came out from the data that was collected at the Kumbh Mela. Nothing can be more important than defining what the Indian population is all about. And we keep talking about, we need to know what the Indian diabetes patient is. And we've had numerous publications in the past to define that, okay, what really we see in the Indian population. But we are trying now to see that can we create a data platform where we can put a collated data from various sources, and this is a work in progress, and have a sort of a common platform by which we could sort of have the data to make our own policies, make our own guidelines, tell the policy makers what the Indian population requires. One of the things that I did was the RSSJ repository portal, and you can go on the website, it is free for downloads. We looked at all the publications that have been done in the last almost about 30 years, and we looked at all the peer-reviewed journals, and we looked at only specific what the data is on the Indian population. I'm happy to say that close to 12 lakh papers we could identify, and we could put them all on a search platform. So today you can go to the RSSJ repository portal and you can put a topic related to diabetes and related to the Indian population, and you'll be able to get all the publications that are in place. I'm sorry to say, but I think there may be still lacuna, there may be a lot of other publications which don't feature there, but we are looking to see that as much as possible we are able to update it. So if somebody's paper which is featured in a peer-reviewed journal is not there, please send it to us, we'll be happy to upload it. So we have every quarterly process by which we upload the papers that don't feature there. Other sources of data collection for us has been the various surveys that we did. In the Defeat Diabetes campaign, we sensitized people on the importance of blood glucose testing. 128 million in 100 days, and we tested 1 million blood sugars in a single day, which featured in the Asia Book of Records. And we had a publication that came out of all the data that we published it in the IGDDC. We had Dr. Vijay Vishwanathan, who has led the 2 successful Save the Feet and walking campaign. And I think at that point of time, Tamil Nadu got the award for contributing the largest number of patients for this campaign. And we could sort of, come out with a lot of guidances. We came out with a atlas book on, diabetic foot, and we published a paper which was in the BMJ, and that was immensely sort of happy. We are very immensely happy to do that. More important, we got a database of 54,000 patients on their diabetic foot, and as Vijay told me that this is the largest data that has been collected in the world on diabetic foot. This is the version 2 now that we have initiated. I urge all of you to be part of this version 2 of the Save the Feet. We started Weight Matters as a campaign from the RSSGI, and we had 4 abstracts in the ADA out of the data that was generated out of the Weight Matters, and that was immensely beneficial because we could come out with some of the guidances that we wanted to sort of put it into our guidelines, and the data that collected was immensely useful. This was something on the pre-diabetes that we did, and then of course hypertension that we recently concluded by Dr. Anuj Maheshwari, Dr. Amit Gupta and others. So Dr. Rakesh Parikh, so many others who contributed to this. And I think Dr. N.K. Singh also is over here, who's been part of this entire journey, who contributed. So I'd like to thank them for all the contributions they could do. We did the India Med study. This is a work in progress to look at the metabolic profiles of a patient population, but we're still in the progress for this. We feel that we shouldn't be concentrating only on our healthcare professionals, but patients remain the most important part of our journey. And we are now creating a patient front portal where every patient can go and get credible information about diabetes, which has been put together by experts, so that they don't have to go to various areas to get their knowledge about diabetes. Education, publications, interactions are always the key to success, and we've now got a very robust e-learning platform where we learn, where we do a lot of learning processes, and Dr. N.K. Singh over here runs the case files on that, and I'm immensely thankful to him for making all this possible, along with Shanma Gavelu and Pratap Jetwani and so many others who've been sort of part. That's it, Shanma Gavelu also, and Pratap Jetwani. These people have been really spending nights to see that how can we sort of have case discussions which will educate everybody about how to practice, how to solve problems related to diabetes. We have a lot of pre-recorded courses which you can visit, and we have now made digital the IGDDC, our flagship journal, and we have come out with the second journal, IJCMD, And I'm proud to say the editor-in-chief is again somebody from Tamil Nadu, Dr. Krishna Sheshadri. So he's doing an incredible job to lead this journal from the front. We've also got an educator journal, that's the Indian Diabetes Educator Journal, and this helps educators on learning how to interact with patients and give them knowledge about diabetes. We have come up with various guidelines, and I'm just going to rapidly go through this, but the crowning glory for us has been, for the first time, we have come out with the nutrition guidelines of the country for type 2 and type 1, and this is in partnership with the National Institute of Nutrition, which is an ICMR body. These guidelines are in publication. We had almost about close to 200 doctors, educators, nutritionists, endocrinologists, various walks of people who contributed to the knowledge in these nutrition guidelines. And perhaps for the first time ever, we have had a structured nutrition guidelines that have come out. And I'm happy to have driven this entire nutrition guidelines, and I think that will be a long legacy to leave behind. Hopefully that, in future, this will help to manage our patients better. We have a number of publications that you can see over here that we have come out with for education purposes. And women have been part of an important journey for us, and women empowerment, and we have done numerous sort of initiatives for women empowerment. So you can see the number of, education processes that we have done for educating our doctors on the nuances of practicing diabetes. I'm going to end up my talk by saying that where is RSSDA now going for the next, let's say, 5 years or 10 years? Because when you sort of develop an organization, the first 2 phases were extremely important. But you need to see that there is a journey forward. No matter who's in the leadership, the journey has to be on the path of development, and we need to see that going forwards, the good work continues to happen, and RSSDA as an organization grows more and more and becomes a flagship for all the world bodies to emulate. First thing that we did was define our goals, and we came up with this white paper to have a vision of what we really want to do, and that's a QR code, and all of you can download this white paper, because we put our roadmap out here in the white paper, that for the future, what should be our areas of work for the RSSDI. We have had numerous collaborations. We've had with the International Diabetes Federation, we've had with the JDRF, we've had with Birmingham University, and so many others. With the Ashoka Universities, we have now set up a partnership to have structured training programs as well as certificate programs, which has been sort of certified by the university, and we look forward to a lot of you engaging with them. We signed a partnership with Quetta Foundation, and we came up with the RSSDA Quetta Center for Digital Diabetology, and this has been the turning point for us, because this has been the defining moment, or disruptive moment, I would say, where we would like to see that technology remains a focus for us as an organization. Because, like it or not, but I think it's
Agarwal, for your excellent, insightful presentation, packaged with a lot of contents about RSSDA leadership activity. Hats off to you, sir. We feel extremely happy and honored. Yes, sir. Please stand. We feel extremely happy and honored. As RSSDA's member, we are working along with you during your tenure as Honorary Secretary General of RSSDA National.
So as Secretary of Tamil Nadu, we will follow whatever guidelines, foundations you have laid, and we will implement and coordinate with you in every action. As you have said, we have already formed the lab parameters. For you, we want you to release this. Yeah. You are going to display in all the clinics, hospitals.
I congratulate Tamil Nadu chapter, Dr. Bhavtarni, secretary. She's been extremely dynamic, and every time I call her up and say, look, Tamil Nadu needs to do this, and she's been forthcoming, and Bhavtarni always says, let's do it together. I'm sure that, in times to come, Bhavtarni will do a great job for Tamil Nadu RSSDA. Thank you so much. Thank you. Thank you. Why don't we have all the executive, NK come up, NK please come up. Who else is there from the Central Executive Committee? Anybody else here? Rakesh was supposed to be there. I don't know, I can't see him. Anybody else? Very proud to release this, and best wishes to you for the successful initiative. Thank you so much.
We need your continued support, sir.
Thank you, sir, for the excellent oration. Now we are moving on to the next session. We are going to have two important keynote addresses. To share these two keynote addresses, I invite Dr. Binu and Dr. A.S. Arul to come to the dais, please. Sorry, that was a miscommunication. We have Dr. A. Muruganathan's session here. It is about wisdom-based medicine, patient stories that have changed us. So stories from legends.
Palamuran, ஆரம்பிக்கலாமா? There is nobody to chair here. ராஜேந்திரன், நீங்க சேர் பண்ணா நல்லா இருக்கும், வாங்க. ஒருத்தருமே இல்லை. Okay. Good morning, everybody. After the nice oration, encasing, I am privileged to deliver this special lecture, Wisdom-Based Medicine, Patient Stories That Changed Me, Stories from the Legend. I think first time the scientific committee, Balamurugan and other people have chosen this topic and requested me to speak about this. In fact, Balamurugan called me about 4 days back only, asking me to talk on this subject. Friends, medicine is not just a science. It is an art and a calling, a lifelong journey of learning. It's about transformation. True growth comes not just from success, but from mistakes. Some of the most profound lessons come not from textbooks, but from the stories of patients whose lives intersect with ours in ways that leave an indelible mark. These are the tales that shape our compassion, refine our judgment, and remind us why we chose this path. In every misstep, there is a message. In every patient, there is a professor. In every moment of doubt, there is a door to wisdom. Friends, let me start with one story of my own story. She is my mother. My mother, a known diabetic, she called me and she said she has some pruritus vulvae. And she complained after some time that there is a small wound in the area. No, as usual, any diabetologist, I told her, no, your sugar is not under control, you have to control your sugar. And then that time I was giving rosoglutasone, which is available. But still, the wound becomes not healed. She called me and said, it is bothering. Then only I realized, okay, we must ask somebody to go and see. And my wife went and saw. And then we did biopsy. And that pruritus ulcer turned out to be vulval cancer. Really, we were shocked. So Sanjay Agarwal will agree with me. See, whenever somebody comes with pruritus, we always think because of the itching, the nail, there is an injury. We took it like that, we were complacent, and it turned out to be vulval cancer. It was in 1998. And we were all shocked. We didn't know what to do. That time there was no linear accelerator even in Coimbatore. There was no cancer center in Tirupur. And we are middle-aged, middle income group, not poor, but still we could not do that because we have to take her to Chennai, take a house because she required radiotherapy and she required chemotherapy, and we have to keep somebody along with my mother. So it was very difficult. That time only we thought we should start a cancer center in Tirupur. So the lesson what we learned in this is never treat your own relatives, kith and kin. And even if you treat, do proper examination, investigation. Don't assume and presume. If only we would have done the first day itself, we could have detected. But luckily for us, the mother was operated. She lived more than 20 years after the operation. The irony of the story is the person, a lady doctor who is my close friend, who operated my mother, she died after 3 months because of colonic cancer. That was a very sad thing, She saved my mother. In fact, my mother was very happy and she gave a necklace to her. We went to her house and gave necklace and said, you saved my mother. But within 3 months, she died of colonic cancer. Ladies and gentlemen, that is why I thought cancer care center is a must, and even in a small town, because every house there is a cancer. That is why, with all your blessings and with all the support, I have initiated this project of 100 crores of cancer care hospital in Tirupur for all the poor people. Now, even the middle income people, they can have the cancer treatment in Tirupur. Otherwise, just imagine a person from Tirupur has to go to Coimbatore or Chennai. They have to take a house. They can take a house, they can take the treatment. But who will stay with the patient? That is a very, very big issue. If it is a local, at least we can have the radiotherapy and come back home. So this is one lesson. Now coming to the second one, a 52-year-old obese individual, a diabetic, had sudden left-sided chest pain. That was the time, 1978. I just opened the ICU. And the patient came with chest pain, typical chest pain. So I was very, very happy that I have a case. So the patient is also rich. I admitted him in ICU, did all the tests. That time there was no troponin. So we did SGOT, everything we did. ECG we took, no problem. Second day I took ECG, no problem, everything is normal. Third day, that patient developed eruptions. Then it turned out to be herpes. So in herpes, even pre-eruptic phase, people have severe chest pain, especially left-sided chest pain. You suspect because he's got a risk factor, obesity, diabetes, and left-sided chest pain. Then it turned out to be, then I felt so ashamed, I told him to kept him in ICU first day, because that was the time I opened the ICU. So the first case which I took, I really felt so bad. From that time onwards, if somebody has chest pain, I also think, okay, maybe if the ECG is normal, I think about the third case. There is one Shanmugha Sundaram who is an exporter. He was one of the 7 exporters in Tirupur who started along with my brother. Very rich person, and he came to me with typical symptoms of ischemia. I admitted him. I took a first ECG. ECG was normal. Then second ECG after 24 hours I took, again ECG was normal. But immediately the patient said, sir, ECG is normal, let me go home. I am all right. Why should I be in the hospital? But I had a doubt because it was strong history and typical history. Luckily for me, his wife and children, they went to US. Nobody at home. I said, nobody at home, so why do you want to go home? You please stay back in our hospital under my care. Let me take another ECG after 24 hours. Then I took a ECG after 52 hours. That ECG turned up to ischemia. So I was so happy. So believe in myself, the history, the science. So that's how sometimes you have to believe in you and then continue ECG, take the ECG, tell them, you can err the wrong side. You should not miss a ischemia. Rather, take 2 days ECG, no problem at all. So that's why. That's the second case. And another person, my servant maid, a 56 years old lady, she has had diabetes neuropathy. And my wife gave her first injection, second injection also she gave, no problem. Third injection also was no problem. Fourth injection we gave when she was at home working, because it's a convenience, no? So we gave beyond B6, B12 injection. Believe me, after the injection she developed anaphylaxis. I was shocked, panicked, I didn't know what to do. Because my own housemate, then I was in Rayapeta living. So I took her to Rayapeta hospital, admitted her, and then we could revive her. Thank God. Then I told my wife and told everyone, never give any injection. Lakshman will agree with me. Even if you are giving an injection, your own kith and kin or your servant, have everything in hand, adrenaline, decadron, whatever it is. Otherwise, try to avoid giving injections. B1, B6, B12, 3 injections were given. 4th injection, I developed this problem. Thank God I was near to the Rayapeta hospital, rushed and then saved her. Then another lady, 45-year-old lady, a diabetic, who always says this symptom, that symptom, dyspeptic symptoms, esophageal reflux, all that she was saying. One midnight, she called me, said, sir, I have a epigastric discomfort. Always the patients will relate story. Selvaraj also will agree. He'll say, this lady said, I had a big dinner in the marriage, and after that, when I came home, when I lie down, I have some discomfort in the epigastric region. Then I said, don't worry, every time this lady used to have the functional overlay. I said, take PPI and then come tomorrow morning. She came tomorrow morning, I took ECG, it's a frank infarct. So, functional, not always functional. You should, suspect, whenever you suspect, take ECG. This lesson, everyone should know. Don't ignore somebody says chest pain. There is a big cardiologist by name Paul Wood. Most of you know Paul Wood. Paul Wood has written a book on cardiology. But he himself had chest pain. He thought it is esophagitis and dyspepsia, and he died. So, a man who has written a book on cardiology died because of the ischemia, because he could not diagnose. So,
Don't, whenever patient says something, listen to him, then take ECG, even if you take 100 times. Then another lady, she's a wife of a doctor. She came and said she has got breathlessness. We did everything. In fact, our cardiologist also saw her. We took ECG, echo, blood test, everything. It was normal. Next day, she came in a state of shock. Then, when we did other things, it found out to be subacute pulmonary embolism. And subacute pulmonary embolism sometimes may not have any symptoms. When I asked the history, that lady had calf muscle pain. She has the history of venous thrombosis in the family. Her mother also had the same thing. Irony is, she had a calf pain, which we did not elicit. Her servant maid gave a good massage in the calf muscle previous day. That made the dislodge the emboli, and then she developed, and next day she came, we lost that woman. Only because we did not ask the history of DVT, and because we never thought about the family history. So subacute pulmonary embolism in the long run can lead to pulmonary hypertension, or like this, frank infarct. Then an young adult came to me with the history of some vague symptoms of numbness, and then when we examined, there was no neurological problem. And we just like that did a MRI, and MRI showed multiple sclerosis. So that day we thought multiple sclerosis should be your diagnosis, because NK Singh every day he sends some images. So you must think about this outside the box also. Sometimes, multiple sclerosis, thank God, we started him on mycophenolate. Till now, touch wood, he is in remission. Then, see, a 52-year-old, my relative, my cousin brother actually, he's a textile mill owner. He called me around 11:30 in the midnight. He never called his wife. Said, Anna, please come. Bob Machan is not well. When I went there, he was in a state of shock, almost pulseless. Then I did CCR. I want to give a message here. Please do only CCR, cardio-cerebral resuscitation. Don't do CPR. You see, 90% of the cases where you have cardiac arrest, in casing, you must also take this to your CME groups. CPR should not be done. When you do CPR, you are wasting time. And when you do the pulmonary resuscitation, the blood circulation to the brain is affected. So 90% of the patient who falls has got only cardiac arrest, not pulmonary arrest. Only respiratory arrest needs CPR. Respiratory arrest will come in the drowning or poison or alcohol or foreign body. It is only in the picture you can see the hero will save the heroine in the drowning and give mouth-to-mouth breathing and romantic things. Every time it not happens. And nobody will do mouth-to-mouth breathing in a road. If a beggar or a roadsider lies down, who will go do CPR? So they will hesitate. I tell you, 90% you do CCR, you can save the patient. Pulmonary arrest or respiratory arrest only in few conditions. And I saved that patient by doing CCR, and then he recovered. Again, he developed a problem. Then I gave DC shock. 2 times I gave, he did not. 3rd time I gave the DC shock, he recovered, and then he lived more than 28 years. And the scar, what I gave in the DC shock, was still there. He's a rich man. He gave a check, plain check, blind, said, you fill any amount. Then I said, no, this is only happiness. I don't fill. He lived up to 28 years after the shock. I feel very happy. Recently only he died. Friends, whenever somebody comes, as a medical council man, I'm telling you, if a young boy came with fever, I admitted him in the hospital and gave paracetamol. I didn't even give him any drip. At 8:30 in the night, after I admitted at 11 o'clock in the morning, the child became unconscious, the young boy. When I rushed, I found, he was unconscious. He's developing meningoencephalitis-like picture. Then when I inquired, he had fever last week. He went to native treatment. He had a tayat in his hand. I did not notice all that. When I inquired, they said the tayat is because he had fever. He went and had mandram kati yendram. Then I told that person, sir, it's a brain fever. Then he asked me, why didn't you, sir, tell me earlier? Why did you admit him? I would have taken him to Coimbatore in a bigger hospital. I felt so bad. I sent him with the ambulance. I followed with the patient, doctor, and 3 days after that only he became conscious. Only then I was happy. Because, otherwise I would have felt bad. So, moral of the story, the lesson, any fever, anybody you admit, say it may turn out to be brain fever. It may be turned out to be something. So that precautionary, otherwise, you'll be in trouble. So this is one lesson I learned then before you do treadmill, see, always, we write, Balamurugan writes treadmill and his cardiologists do ECG, treadmill. Inquire whether he has got angina symptoms that day or previous day. Do a resting ECG. Don't do a treadmill without taking a resting ECG or getting the history. Once a person was sent to a cardiologist, my patient, he had some vague chest pain. They did a treadmill. On the treadmill, he developed infarction. So please don't do that. Check. Then, always aware of the local culture. I think all the diabetologists, Giri will agree with me. Here in Tamil Nadu, there is a ritual called Pradosham. Pradosham, I don't know how many of you know. Ladies observe Pradosham. Pradosham means from morning to night they don't eat anything. And without knowing that, we gave injection, insulin continued, and she developed hypoglycemia. So understand the local custom. If Unikrishnan in Pune, he must understand what is the local. Though he is a Keralite, he must know what is Pune, what is the culture there. Then treat accordingly. Then medico-legal case. You see, always a poison case, if you see, be careful. Once what happened, a young lady who is married, only 3 years married, up to 7 years is a medico-legal. Suicide death is a problem. They came to my hospital at midnight, 2 o'clock. I went and saw in the car, she was almost dead. I said, please take it to GH. Then GH, they found she dead. The police, deputy superintendent came next day, said, what is the observation? You only saw the patient. I said, I didn't see the patient. No, you only saw the patient before she died. You are the only person who saw. Unnecessarily, I was in soup because I have to give all the explanation. So, always, when you give a life certificate, don't give life certificate. Even if you give life certificate, don't give without date. And if somebody comes, a stranger, when you take a ECG, I took a ECG for a patient, it was infarction. I told him, it is infarction, get admitted. He did not get admitted, he went out. In the corner of the road, he fell and he dropped down dead. And some ambulance, not ambulance, the truck, dying factory fellow saw that. He took the same patient, brought it to me with broad dread. So I didn't know. I was there having only ECG only, no record. Till evening, nobody came. The police came, inquired, we did postmortem, all sorts of problem. So, ladies and gentlemen, the most powerful diagnostics tool is not technology. It's time and empathy. Listen more, examine deeper, and serve with greater compassion. When we truly listen to our patients, their stories, give the silence, will give so many newses. What do these stories tell us? Mistakes are not the end. They are the beginning of the mastery. Patients are not the cases. They are the teachers. Medicine is not perfection. It is evaluation. Let's be bold enough to accept our errors, humble enough to learn from our patients. Friends, you must understand patient. You should understand disease. You should understand drugs. One of the important wisdom I would like to share when people like Sanmugavel, Balamurugan, Ram Kumar, everybody is there. The lesson I learned, the wisdom I learned in my practice, have a balance between your academics, practice, relations, and health. I am not a good example because my wisdom, after I get this, I get addicted to your clappings and round of applause. And every day I don't go without shawl, without a memento. My sleep is not good. until I see many people hug many people, shake hands with people. This is not what you should do. I am a bad example. Because when you do all that, every day, if Unni Krishnan goes every town, his wife will scold, his practice will go down. And and your academics is good, NP singing is academically good. But his health, his practice goes. So I told Balamurugan, please balance. He is good. He always balances. He takes his wife somewhere or other, give her a sari, give her gifts also, I know. So like that only you have to balance your life. First is personal health. Self-service is not selfish. Self-service is always good. Take care of your health. That is why in the Indigo they say, before you help others, you help yourself. First is personal health. Second is family health. Third only other things. And practice, when you do practice, please focus practice also. Don't go like me. Be like Lakshman. Wherever he goes in a very good way. He only has academic out of practice only. Practice hours he will not sacrifice. So practice is important because we are not giving pension. See, I am a private man. I don't get any pension. Only practice. But I have no practice now because I go everywhere. Today I am here, tomorrow I am in Chennai, day after tomorrow I am in Delhi. Very happy. But what is the use? No money. So practice is also there. Practice is also should be there. So the wisdom is, don't leave practice. Have a good academic knowledge. Have a balance between your health, family, and all these things. That is the message. Thank you very much for giving me this opportunity. Wonderful. Thank you. Thank you.
Let us all give a standing ovation to the wonderful words of wisdom by Sir. So moving on to the next session. To chair this session, I invite Dr. V. Rajendran and Dr. P. Dharmarajan to come to the dais, please. I request the chairpersons to kindly introduce the speaker.
Welcome, sir, Dr. N.K. Singh. We all know him.
Yes.
One of the, I'd say in the country, in the top bracket, who is really a person for whom academics come before everything else. He's a diabetes care physician from Dhanbad. He's the director of Diabetes and Heart Research Center, Dhanbad. He's an executive member of the National RSSDA. He's an ex-governing body member, National APA. He's an ex-chairman, APA Jharkhand, and chairman, RSSDA Jharkhand. Edited Millennium Book of Medicine, RSSDA Case File Book, 2024. He was an associate editor, Postgraduate Medicine, 2021. Edited monograph on COVID by ICP, API 2023, RSSDA Case Book, series. Over 45 national and international publications. Admin and founder, CM India WhatsApp group, in which even I am a member and I enjoy reading your messages, sir. He's an editor-in-chief of www.cmeindia.in. With this, I'll ask him to give his lecture.
Good afternoon. With huge thanks to all our chairpersons and all this Tamil Nadu team, I think a wonderful meeting. And after Sir Muruganathan sir has given us such energy to all the, I think, here the audience and to me, that next 15 minutes, let us see let us recollect something again from the Benedict solution to time in range.
Here, Dr. Unnikrishnan is here. He is the, I think, the world star of the diabetes. And I really don't think that, sir, whether you have used Bendit solution or not. You might not have. You have used, okay. But many of you, the younger generation, might have not used it. And today everything has changed in diabetes. So let us, and this is not something which a bookish thing I am going to show you. This is from my own experience of the diabetes. It was 1974. There was a movement known as JP movement, Jayaprakash Narayan movement. And my brother joined a movement. That movement left the education. And my father was a police inspector at Jamshedpur. And with that incident that he left the education, there was a severe mental stress. And a person who was totally healthy before became diabetic. So that was the first time in 1974 I recollect that I had some memory of that, my father, that time, that then the local physician came, he educated about this Bendit solution, and this is how the diabetes was in my memory from 1974. If you remember back in 1925, played a major role this home testing in early diabetes screening and monitoring. And after that, this was notorious for persistent hypos. I still remember that time the only drugs which were available were Dionyl and the DBI. I don't know many of you have heard about the DBI. But Dionyl is still available today. And then my father had got a severe hypoglycemic episode at a remote place. And for 3 days, we were not able to diagnose what is happening. There was persistent hypoglycemia. So this was still, you must be aware that Dionyl is notorious, or glibenclamide is notorious for that. With that, my father was shifted to Mumbai, and the physician changed to fenformin. And I think, Dr. Unnikrishnan, I don't know you have got any experience with the fenformin again, with the DBI-TD, but my experience with the DBI-TD is very, very good. Although that was a very good drug, only banned due to the fear of the lactic acidosis, but I still feel it was not so a practical problem, it was a rare problem. But anyway, science is science. So fenformin was discovered in 1957, and then it was banned. And then lots of storage. But what is happening today in diabetes? Einstein once suggested that they keep doing the same thing and expect different results is the definition of insanity. And this is what we are doing in the diabetes. In our world of diabetes, we seem to be guilty of this by failing to appreciate that a new ways of delivering care are necessary if we want to make progress. And the race against diabetic complications is a marathon, remember, not a sprint. So now, from HbA1c to time in that, and tight time in range, now the concept is coming. Very tight time in range. So time in range will be not enough in days to come, and you have to keep your patients in tight time in range. So from gold standard to, we are moving to CGM metrics. I will not go in detail about what is time in range and how it has become a gold standard now for our patients. Let us see some more things. The lighthouse concept in diabetes. The lighthouses don't go running all over an island looking for boats to save. They just stand there signing. So to be clear, sensible medicine does not mean that weak physicians should not intervene. So this is happening, you are doing it. So we are not following what the guidelines are saying. Sometimes it is your experience, your way of life, your way of thinking that is supporting our patients, and you will agree for that. And then came the very important and miraculous drug, this SGLT2 inhibitors. And now initially I remember that it was initially a diabetologist drug, then it becomes a cardiologist drug, then it becomes a nephrologist drug. So it is changed so much. So what is happening at the primary health centers and at remote places? Diabetologist is focusing on the blood sugar, nephrologist on the kidneys, cardiologist on the heart. But basically we physicians are doing all the harmony with all these cardiology, nephro and other parts. So I feel that diabetes communications we must change how we are going to intervene to all patients. And you can see this slide, 2/3 of Indian diabetics are undiagnosed. 2/3 of dysglycemia is pre-diabetic. 2/3 of patients of diabetes are young. 2/3 do not have HbA1c measured even once in previous year. And 2/3 of patients of diabetes are uncontrolled for HbA1c values. And in the same way, there are lots of stories to tell you. So this is how I started the CME India. And now it is well established from this Nature group of publication, the BMC, this has become, the digital communication has become a very, very important way. Even in this such conferences, I don't think that whatever we are seeing it and what we are telling you, you are grasping to all. Many times it becomes just part of developing communication to your friends and other things. But the real learning with the explosion of knowledge today is only possible through the digital knowledge. And this is what we did in the COVID time. We learned with all the Zoom meetings, and then from person, that patient, and accordingly you can behave. So diabetic then, but the second part is diabetic distress is rising, and there is no need of fiction in medicine, for the facts will always beat anything you fancy, and data and science are useless, as Dr. Murnathan told you, without art. And this is, I find that in Jharkhand areas, can we use an insulin storage device from RSSDI? And sometimes even the exercise doing, what we are telling your patient, go and do exercise. Do we need to teach such persons? Yeah, what are the exercise types? This is aerobic is important, or resistance is, they are already doing that. Even that these entities are not diabetic gestures. They are dancing other things. And all, then you go for the all Jocelyn course, the diabetics who knows the most, lives the longest. And it is better to discuss how far you have walked than how little you have eaten. And well-trained nurse is of more value than a patient doctor, remember. So these are how things are changing. So what has not changed from Bendix solution to the time in range is the 225 vision of longevity for diabetics. I'm not going details, but this is a very, very exciting field to discuss how the sleep, the circadian rhythm, the sunlight exposure, the nature and social connection, even the grounding, personalized diet, vegetables, using genetic data, exercise regimes, meditation, mindfulness, lots of things are happening. And whole problem is what? You are taking more and more food, and you are not expanding that, not going to burn that. And then there are oversupply and the undersupply. This is the main reason of problem in today in diabetes. I will end here with that. Think also about the endocrine disruptors, then increase the telomerase, then the gut microbiota, and always show this slide to your school children that how these diabetic superfoods can protect, and we are not propagating this one, how the physical activity can do, what Surya Namaskara can do, and other things. With last slide, that precision diabetes based on genetic testing is a new concept for diabetologists. Genetics is not a part of routine clinical training at present. Traditionally, the specialty of diabetes emphasizes based on treatment rather than diagnosis. And so with that, precision message in diabetes is very, very important. And thank you very much that this was a disclosure from the ADA. If we do not know what causes type 1 diabetes, and we do not know at present what causes type 2 diabetes. Thank you very much. Thank you for inviting me. Thank you.
Thank you, Dr. A.K. Singh, for that excellent lecture on the topic, how diabetes care has evolved over the years from Benedict solution to precision medicine. And I particularly like that one slide which you projected when you stressed upon the importance of understanding precision medicine, that 80% of our treatment is going as waste, and how we have to move towards precision and personalized medicine to correct ourselves. Thank you for that excellent lecture, sir. So we'd like to join you on the stage. And next, we'll have discussion at the end of the session. Next, I would like to call upon our senior physician from Chennai, Dr. S.S. Lakshmanan, sir, who is a senior consultant physician, a very knowledgeable academician, and with more than 5 decades of clinical practice. He has been there in all academic forums to teach us about how, on the topic case-based discussion on young diabetes. So, over to you, Dr. Lakshman, sir.
Thank you, Dr. Dharmarajan. I present a very nice case, very interesting case of a very young fellow diabetic I treated about 1 month back. He's a 13-year-old school student. He's a pure vegetarian Marwadi boy, was admitted with a high fever, abdominal pain, continuous vomiting of 3 days duration. He's a known case of type 1 diabetes on basal bolus insulin for the past 2 years. He was evaluated for abdominal pain in the year 2023, and he was found to have a hydronephrosis of the left kidney with elevated blood sugar of more than 600 in a corporate hospital. So they shifted the patient to a diabetes specialty hospital for sugar control before surgery. He was treated with insulin therapy and was investigated and diagnosed there as a type 1 diabetes. The previous hospital 2023, the A1C on admission was 17.5%, and the fasting C-peptide was negligible. The postprandial stimulation has just give 0.2 picomoles of C-peptide. GAD antibody was negative in the hospital where he was treated on the year 2023. The diagnosis made in the hospital was the diabetic ketosis with type 1 diabetes. He was started on basal bolus insulin of the insulin R, 15 units 3 times a day, and 25 units of the glargine insulin at bedtime. After 5 days, it was not sufficient. The insulin was escalated to 18, 20, 18 of short-acting insulin and the 25 of the glargine insulin. He made him fit for surgery. He went back to the corporate hospital where he underwent a left kidney pyeloplasty with the basal bolus insulin coverage and was stented. The stent came out within 3 months' time. The repeat stenting was done after 3 months again. Now, after 2 years, he presented to my hospital with a diabetic ketoacidosis with a severe urosepsis. He was febrile, toxic, he was extremely dehydrated, the pulse was 132, respiratory rate was slightly hurried. Very, very lean boy. He was BMI was less than 18, weight was 36 kg. Abdomen showed a severe left loin tenderness, no markers of insulin resistance. He has given a history, the operator for left congenital hydronephrosis and DJ stented 2 years back. There is no family history of diabetes. Random sugar was 620, A1C was 16.8. Urine were densely have ketones with a lot of pus cells and RBCs. His USCR was positive, urea was 56, creatinine 1.4. He had hyponatremia of 128, sodium, potassium was 5.4, and chloride 98. LFT was normal. You can see the sepsis, the total count was 32,000 with a polymass of 84, and the CRP was 130 milligrams. Chest was normal, EC showed a tachycardia, echo no LV dysfunction. Scan abdomen showed a residual hydronephrosis left kidney with a severe perinephric fat standing, suggesting acute pyelonephritis. Serum hydroxybutyrate was positive. The diagnosis was diabetic ketosis with the UTI, with the pyelonephritis, with the type 1 diabetes. Shifted to ICCU. He needed, we started on IV insulin therapy. He needed about 5 to 8 units of IV insulin every hour to almost 150 units per day to keep the blood sugar less than 180. Given meropenem, saline, standard care for diabetes ketosis in ICU, the RFT became normal in 3 days' time. After shifting to the ward, he needed the 5-ASP insulin, the very short-acting insulin, 18 units 3 times a day, and the Tresiba, the Degludec insulin at 30 units at bedtime, just to keep the blood sugar between 180 to 240. He was advised insulin pump by me. The parents were not willing. It was very difficult to control the blood sugar with the below 180 milligrams. Now the problems in hand is that the patient has got a sugar of more than 600 4 times, diabetic ketosis 3 times, pyeloplasty left kidney once, DJ stenting was twice, recurrent UTI. He needed a very large dose of insulin, still the sugar not under control, very pathetic looking boy, BMI of 18, weight of 36. The pump is the only solution. Are we missing the diagnosis, or the both sides of the metro train looks similar? After 1 month, I again wanted to check the GAD antibodies and the C-peptide levels. Again, the GAD antibody was negative. Probably it belongs to a non-GAD antibody positive type 1 diabetes. C-peptide, again, the fasting was 0.3 nanogram and the stimulated was 0.8 nanogram. I don't there is stimulus that the beta cells have, some living beta cells. We are puzzled, unsure, is a whole family were reluctant to get the patient on insulin, so much of insulin. I went back to the classification of type 1 the diabetes, whether we have the same type 1 diabetes or different type 1. We have this boy, classically looking, ketosis prone, malnourished boy, type 2 diabetes. We know the specific types of diabetes. I have had shown you last, I think, presentation, a young fellow who was treated for 3 years as a type 2 diabetes. On the 4th year, we found out the boy had a Cushing syndrome. So please see that the secondary types of diabetes not to be ruled out by any means. It's not a GDM. There's a condition called type 5 diabetes. I was attending the Bangkok IDF April 8th, 2025. They reported a first case in 1955, BMI less than 19, very high blood glucose. They always need insulin, but usually they don't develop ketonuria, in contrast to my case. So whether my case belongs to a type 5 diabetes. This is a type 5 diabetes. I sent the sample of the boy, informing the parents that I'm trying my level best for a very precision diagnosis, and I waited for 8 weeks. The results came. Anyone want to discuss this case before I disclose the diagnosis? Chairman, audience. I think some of you would have heard this case before. Okay, I presented once or twice in a forum. Why? Yeah, I think there's a good diagnosis. I think the results came. The results came after 2 months. It took 8 weeks for the genetic studies to make a diagnosis. Dr. Mohan wrote a letter, congratulations on picking a case of HNF beta MODY, the MODY 5. The MODY 5. But he cautioned me that the MODY 5 is exactly like type 1 diabetes. Most of them require insulin. The Tattersall-Pajan's criteria, the one which gave a clue that there's 3 generations of people with the diabetes in the family, early onset, non-insulin dependence, absence of obesity, and they classically given absence of diabetic ketoacidosis. Probably the time where they had a Pajan's and Tattersall, there were only type 2 and type 3, the MODY type 2, type 3. They do not go for the ketoacidosis. That was the one MODY 5. As you could see here, the defect is in the HNF1 beta and the severe kidney disease, pancreatic hyperplasia, and any female genital organ abnormalities. I think the message is very clear to you. Somebody presents with a type 1 diabetes like picture with a renal abnormality. That's the one. The organ which is affected is kidney. More than 90%. Please think of MODY 5. The common MODY, what you get in your practice is the MODY 3 and MODY 2. MODY 2 is the glucokinase deficiency. HNF-A deficiency is the MODY 3. Of course, the syndrome is called the RCAD syndrome. I think there was a mention on the floor that whenever you have a renal cyst or and diabetes, it's called the RCAD syndrome. That's the gene which is carrying that MODY 5. 17q, which is the focus, this is called monogenic diabetes. MODY 5, the HNF beta gene and the chromosome 17q. The first case was actually reported in the 1997 in the Japanese family. HNF1 beta is encoded by the human transcription factor 2 gene. And this variety of organs it is expressed, including the kidney, pancreas, genital. That's why they are always present with an abnormality of an other organ, either a kidney or a genitourinary system. And the more maturity onset of diabetes, now we have the 15 subtypes. There are 14, I think 15 was reported by Dr. Mohan, among which the MODY 5 accounts less than 5%, and it has got number of extra pancreatic manifestations. Type 1 diabetes and MODY share similarities in the early onset, potential for misdiagnosis with type 1 diabetes, and the ability to cause similar diabetes-related complications. MODY 5 always require insulin. Then how did I treat this case? As I told you, this case called ORCAD syndrome. I went through the pathophysiology of the HNF1 beta associated MODY. They mentioned that there is a pancreas still working. The pancreatic hyperplasia resulting in beta cell hyperplasia results in decreased insulin secretion and release, but there's an increased hepatic insulin resistance which plays a major role in the development of diabetes. So the severity of the pancreatic hyperplasia determines the severity of the hyperglycemia and possibility of ketoacidosis at early presentation. So possible mechanism of MODY 5 include insulin secretion defect, insulin resistance, and abnormal glucose sensing mechanisms. So always I said somebody is even for a transplant, patients posted for type 1 diabetes, please rule out that the patient does not have a MODY 5. There's a case report from the MODY 5 in the Indian literature. A diagnosis more often missed than made. That is a IGM case report. Of course, I'm writing this for our Tamil Nadu APA journal. Today I met Dr. Vijay. He said it has been accepted for publication. So despite being a rare case, MODY is underdiagnosed and often treated as a type 1 diabetes. With regards to treatment options also I went through, they say sulfonylurea can be used as a first choice in MODY 5 because they have still some working beta cells. Its efficacy is often less in MODY 5. Patients often require early insulin therapy. I took a chance. I started this guy on glycoside, metformin, the dimicron 30 milligrams MR twice daily, pioglitazone 15 milligrams, metformin to break the insulin resistance, and I also gave him the Tresiba insulin at 15 units at bedtime. To a surprise, within about 3 months' time, this guy put on 10 kilograms of weight. The A1C reduced to 6.8 from 16.8. The fasting sugar came to 104 and the PP sugar came to 164. Absolutely, the infection in the urine has disappeared. There's no perinephric fat around the left kidney. There's a guy who came actually about 15 days back to now he's 56 kilograms. He was 36. Now he's 56 kilograms. Still now the A1C is maintaining to 6.8. I don't know how long it's going to work. I think I told him to have a nice diet control, do a lot of exercise. I think primarily breaking his insulin resistance, though he doesn't have insulin resistant markers in the external appearance. I think it's again very important carry a message that the cases which mimics like a type 1 diabetes where we have a horrid end, patient requiring so much of insulin, 100 to 120 units of insulin every day, and now we are shifted back to normal. Now he is studying about 7th standard in a school. Thank you. I think I'm happy to welcome any questions from the floor. Thank you very much. Thank you.
Thank you, Dr. Lakshman sir, for that excellent case description. Now, if there are questions from the floor, Shanmali sir, yeah.
A nice presentation. My question is, whenever there is hypoplasia, it affects both exocrine as well as endocrine cells. With reference to endocrine cells, both alpha and beta cells.
He never had any exocrine deficiency of the pancreas. There's no exocrine deficiency has been reported in, it's only beta cell hyperplasia. not pancreatic
Because
hyperplasia.
it was mentioned as
Okay, sorry.
pancreatic
Okay.
hyperplasia. So only beta cell.
Yeah.
So that means intact alpha cell.
Yeah.
That would have caused hyperglycemia and ketosis. As long as the glucagon secretion is there, definitely in the presence
There was
of
an option by Dr. Pannirselvam that why didn't you give DPP4 instead of sulfonylurea? Where he said he will suppress the alpha cells.
Thank you, sir.
Mike is please.
As we approach analysis, before you got the genetic, just now you got the type. Before that stage, can we think is a form of mitochondrial diabetes at this stage? Where GAD antibody is negative. It also has got an abnormal genetic marker.
No, I didn't think of mitochondrial because normally this comes in genetic form of diabetes where they have all other manifestations of the congenital problems. I think the boy is quite healthy to look at to make a diagnosis of mitochondrial diabetes. I think it's ruled out.
Yes.
Clinically it's ruled out.
Right,
Thank you very much.
Thank you. So thank you everyone. Thank you sir and thank you Dr. A.K. Singh for that excellent lecture and the case discussion. And the lesson that we learn is that don't take the diagnosis of type 1 diabetes on its face value and go ahead and investigate so that you clinch the diagnosis. Thank you sir.
Thank you. Thank you.
We'll move on to the next session.
Thank you, chairpersons and speakers. We are moving on to the final but very important session of the day. It's going to be the Dr. M. Vishwanathan oration. To chair this oration, we invite Dr. J. Giri, Dr. P. Dharmarajan and Dr. Vijay Vishwanathan to the dais, please.
Ladies and gentlemen, now we go on to the final oration of the day, Dr. M. Vishwanathan oration. And may I have the privilege of requesting the speaker, Dr. A.G. Unikrishnan, over to the stage, please. We also request the presence of Dr. J. Giri. Dr. Giri to the stage, Dr. Dharmarajan, Dr. V. Rajendran, the chairman of the conference organizing committee, and Dr. Balamurugan, the secretary of the organizing committee. May I now request Dr. Dharmarajan to kindly come and read the citation.
Professor M. Vishwanathan oration, RSSDI Tamil Nadu chapter, with great pride honors Dr. A.G. Unikrishnan, a distinguished endocrinologist, visionary leader, and passionate educator, with a Professor M. Vishwanathan oration at Trac2025. Dr. Unikrishnan serves as CEO and endocrinologist at the Chalaram Diabetes Institute, Pune, where he also heads patient care, research, and education. With over 25 years of experience in endocrinology and more than 230 indexed publications, his contributions span pioneering clinical research, impactful public health initiatives, and transformative medical education. A former faculty member at CMC Vellore, Banaras Hindu University, and Amrita Institute of Medical Sciences, Dr. Unikrishnan has trained generations of physicians and endocrinologists. His leadership has guided major collaborative studies, including the Indian Pancreatitis Study Group and the MEDI study on early onset diabetes in India. He has been principal investigator in numerous national and multinational clinical trials shaping diabetes and endocrine care in India and beyond. Under his stewardship, Chellaram Diabetes Institute has become a hub for excellence in clinical care, research and capacity building with landmark initiatives such as the ACMDC and CCMTD certificate courses, rural diabetes outreach programs serving over 900 villages, and innovative e-learning modules accredited internationally. His illustrious career is adorned with numerous accolades, including the Professor Sam G.P. Moses Oration, Dr. C. Munichodappa Oration, P. Kesavdev Oration, MGM Diabetes Oration, and the Dr. Mohan's International Diabetes Update Gold Medal Oration. Recognized for excellence in diabetes technology, patient care and education, Dr. Unikrishnan has been honored by prestigious national bodies and state governments alike. Beyond his professional achievements, Dr. Unikrishnan is known for his clarity of thought, commitment to ethical practice, and ability to bridge science with compassionate care, values that resonate deeply with the legacy of Professor M. Vishwanathan. In recognition of his outstanding contributions to endocrinology, diabetology, medical education, and public health, the Tamil Nadu chapter of RSSDI is privileged to confer upon Dr. A.G. Unikrishnan the Professor M. Vishwanathan Oration at Trac2025.
Thank you, Dr. Dharmarajan. Kindly hand over the citation. And in the meanwhile, Dr. V. Rajendran to adorn the medal on. And Dr. Balamurugan. Okay, Dr. Giri to kindly hand over the citation. Dr. Balamurugan to adorn the shawl on the speaker. Dr. Dharmarajan to give the memento. Thank you, gentlemen. Over to Dr. Unikrishnan for the oration lecture.
First of all, I'd like to thank the entire team of Tamil Nadu RSSDI for choosing me and for this oration, Professor M. Vishwanathan oration. I'm touched and moved, and the greatest gifts that we as doctors get are the blessings that we have from our patients and more importantly from our peers. So the award given to me by medical colleagues is at the highest of the high honors, and this is one of the most important days in my life to receive this oration. And whenever I come to Tamil Nadu and Coimbatore, I find I am with friends and well-wishers, and the positivity is huge. I thank Dr. Balmurugan, Dr. Rajendran, the entire Coimbatore team, RSSJ team, for honoring me and choosing me for this oration, and also to Dr. Mohan as well, and Dr. Vishwanathan and the rest of the family, Dr. Vijay Vishwanathan and the rest of the family. Of course, it is very humbling to stand even in the oration name of such a great person like Dr. Vishwanathan, Dr. M. Vishwanathan, who is a pride of India, and I will diabetes clinic, they take care. And if you see abdominal obesity in rural women, this is the paper we published, and we found that whether you look at men or women, there's a huge prevalence, 30 to 35% prevalence for obesity. And if you see this diagram, this picture, this is in the mobile diabetes clinic, and you'll see all the women are waiting till the men are first to get into the queue for the checkup. Our mobile clinic also has a TV where we run some diabetes videos to watch. And this diagram shows you, when you look at it carefully, the men are not doing all the hard work. They are in the fields or in the side of the fields, they are talking, but the women do the hard work in the field, they take care of children, and even to get health care, they are the last. Men actually go in quickly. And they are all men, and we men are always happy and good people. All of us are good people, but when it comes to making sure that women also get the same care, women also participate to the same extent in any activity. It could be healthcare, science, education, technology, engineering, medicine, whatever it is, and that's very important. And this is me with the mobile diabetes clinic team, and you can see all the men standing. So this is important. This is another child, a small child with type 1 diabetes from the mobile clinic, and this girl has no access to insulin. She gets insulin only once in a month. When her father brings insulin and she gets the insulin, she feels so happy. On the days when she does not get insulin, she has abdominal pain, maybe even subclinical ketosis. This is Dr. Vedavati Purandare. She is the head of our clinical care in the hospital, and she saw this patient and we helped out this child. So this is the reality of diabetes in India. The reality is not the diabetes that you see in urban practice where you do HbA1c, biotheometry, ABI, you do CT angiogram, you do fundus photography. All that is there, but there is no awareness and nothing in rural parts of India. And that experience, we tried to get more experience from it. So this was our model. So we studied more than 900 villages. Take a small village, our ASHA worker or accredited field workers, the community health workers, will go to the small village and enlist see all the people in the small village. She will do a questionnaire, which is not the diabetes risk questionnaire that is there, but modified. We added things like, do you have eye problem? Do you have foot problem? Do you get recurrent infections? So we added all that to our scores, and then we called the patient. And then when the mobile clinic visits the spoke, the ASHA worker will bring the patient. So from the hub, our mobile clinic will go to the spoke, and in the spoke village, the ASHA worker will round up all the patients. So we did what is called high-risk screening. And this is, of course, now we have done 10 times that number. We found that the pickup rate, that 1 in 5, if you screen, will have diabetes. So instead of screening everybody, it is better to do high-risk screening. This is the design of our mobile clinic, and we can share it with you anytime. There is a registration, there is a examination, and this is a registration. The patient comes like this, registration is done, patient lies down here, examination is done, and then there is a fundus camera, and there are few seats for patient to wait, and after they finish, they exit through this mobile clinic. So this is how it is: the registration, the examination, the fundus evaluation, the glucometer testing. For sometimes we even had point of care HbA1c testing for a short project. And our project actually was cited by the ICMR in their white paper, that they said that instead of asking the patient to go from their house to the PHC or primary health center or hospital or lab for screening, we should innovate and get ways where you can get a mobile diabetes clinic or anything to go to their patient's house and then do the testing and then give them awareness in diseases, chronic diseases. That is more important. And to do that, we have to harness what is called community health workers or accredited social health activists. So we looked at our project from the eye of obesity, and we looked at 29,324 initial patients we studied. We found that almost 26% are obese. So we have an impression that in rural India, people are all working in the fields. They are very active. They eat little food and they are very muscular and healthy. No, that's not true. In fact, when I went to one of the villages, I met a potato farmer. I found that the potato farmer was making potatoes, but he had a packet of Lay's chips in his house. So the same potato he is selling to the company which is converting them, processing them into the unhealthy Lay's chips, and then he is eating that. So if you see, in the villages also, you will find nothing to do with Lay's chips. I'm just explaining that you will find fast food, and because of mechanization of farming, people don't have to really do hard work in the farms. Maybe in the cities we may have to do hard work, but in the farm we don't have to do hard work anymore. It's all mechanized, and because of that, sedentary life think just basic minimum medicines and diet can bring down that community's HbA1c from 8.79 to 8.2. And that result told us that we are onto something. And you can see that this was also reflected in LDL cholesterol. So we found that this project, which is called Project Diabetes with Dignity Intervention, is especially effective in reducing HbA1c in people with diabetes in the intervention group, and capacity building of community health workers is key. After this, we approached the Maharashtra government and told them that we have this project, these are the results. They took it on. See, we don't have to do everything. Once we run our community project and show the results, they took it on. They said, we will do it. Give us your training materials. And we have shared it with everybody. In fact, we can share it with you also. We translate it into Marathi and we can share it with everybody. And this community intervention has been now taken up by the Maharashtra government. And as I mentioned, they have used all our materials, reading materials, our programs. So even the PHCs where we did capacity building, one day of the week, the PHC made it as a diabetes day, diabetes clinic day, and they had we made a separate book for them, how to monitor the sugars. And this made sure that the PHC was empowered. In order to close the loop, we also met all the private practitioners of the city, of the villages, and we trained them also, because not every patient will go to PHC. So in the intervention arm, our community health workers went house to house. Capacity building was done at the PHC. We also trained all the local doctors. Then we saw the outcome versus the comparator group, and as we said, we found the A1C came down. This project was very much liked by people, and want to thank many people, Dr. Damodar Bachchani from the ministry at that time, Professor Nikhil Tandon, Dr. Srinath Reddy of the Public Health Foundation of India, Dr. Sadhana Taide, who was in the government Arogya Bhavan, and this helped us to work on the next project, which was childhood obesity prevention, where we did school programs. Many of us you also know that we have tried to reach out to patients in our magazine Diabetes Health, which is now in its 12th year. There are many magazines for diabetes, but our magazine has stood the test of time and is continuing, and this is the end. So these are some of the new projects we have undertaken at the Chalaram Diabetes Institute, and this is Chandu Champion, one of the heroes who worked served India, and they came. And we also tried to build a local community through our wellness center, where the local population around where we stay are empowered in diet, exercise, physical activity. This is the new project that we are coming up, and this project and our newer mobile clinic goes beyond diabetes. We look at women's health, breast cancer, and screening for women's health, and that is our new program, and that is coming up in our new building. And as I said, it's not the village people who work hard anymore. Sometimes even we have to work hard. You can see me, inaugurating, though I do only that. We as doctors don't have to do other things. So friends, on that note, I've talked about diabetes management in India, of how diabetes is there in the villages, how people suffer in those villages. Second, I discussed our experience in the community, how we found that there was a man with diabetes who had foot amputation, toe amputation. He tied up with a socks and he was walking. How a child did not even have insulin to take in the remote villages. And I talked about those real life stories. And third, I talked about how we, at least I call it the Pune model. Pune is known for many types of research, but I call it as a Pune model, where we are able to capacity build community health workers, and that made a huge impression in diabetes. And I showed you a comparison of the two sets of villages, the intervention village and the control village, and how a simple intervention of monthly visits by ASHA workers can dramatically change the A1C. So before I end, I want to thank all the institutions I worked and studied in. In my school, I studied in Chinmaya Mission School, and Swami Chinmayananda, he was one of the people I looked up to in my childhood. Then I studied at the Kozhikode, the Calicut Medical College, and I met one of my juniors here who's actually here, 5 years junior to me. I spent a lot of time at the Amrita Institute of Medical Sciences as a professor. I want to thank that institution. I see some of my, at least two of my diabetology trainees are here in the audience and they are practicing and very successful. One of them has raised their hands. Dr. Gauri is here, and the other is of course Dr. Ramesh, and happy to see them all very successful. Ramesh is here, all doing from Dindigal, all successful diabetologists, and that gives us happiness as well. I want to thank Amma, because Amma's grace is something which has showered on me throughout the years, and for 3 generations we are devotees of Swami Satya Sai Baba. I'm a Balvika student, and I want to thank all these people, including my family, who have made me what I am, and of course all of you, because I may be able to talk, but unless I can share it with doctors here, each one of you here, only then that gives me happiness, that carries the message, and that we get the feeling as we doctors can get together and build something. I also want to thank all the institutions we work with, the CSIR NCL Pune, the Ministry of Health and Family Welfare, the Maharashtra Arogya Bhavan, the Public Health Foundation of India, the Zilla Parishad, as we embark on our 3rd program, and also the members of the Chalaram Diabetes Hospital. This is our cath lab, our dialysis unit, and of course our expansion plans are in progress. Friends, it's a pleasure to give this oration. It's an honor for me, and I enjoyed myself thoroughly and felt touched at this honor bestowed on me. I thank you very much, and thank you for inviting me here.
I think this oration deserves a standing ovation. Thank you, Dr. Unikishan, for that excellent oration. And it is really surprising and heartening to see how a consultant endocrinologist can do so much of community service to the people of the nation. Thank you for that, sir. Thank you.
Thank you, Dr. Unni. Yeah, we are honored to have you here, and we are delighted and to see all your achievements. Probably we will, all the RSSDA members of various positions can just try to be in touch with you and try to imbibe something from what you spoke and what you presented. Thank you very much. With this, we'll go for lunch and come back, and we'll have a quiz final program. Panir, oral quiz finals is there, and we have a morning free papers presentations finals, best of track will be presented here. Yeah. After that, the valedictory is here. Thank you. We'll go for lunch.
I request all the candidates who participated in the quiz prelims yesterday to please go have your lunch and come back at 1:45. Yeah, 1:45. 1:45 I want to hear. Those who are not coming, you will not get the taste. Okay, all right. So what?